So, Mansoor, hola, hola, how are you doing? Let me try and send this out. I wasn't gonna pop on tonight, you know, but I was like, all right, so I'm in the mood. I want to do a speed round, so let me just check out who is here, and then we can actually go through a few questions. Where my thing gone? Yeah. So I'm doing that. I'm trying to send out this live. How long time I'm gonna talk to Luminous? Oops, it's me. How are you doing? I was wondering if you were online, you know, because I'm like, all right, I'm gonna prepare a few pediatric question, because I know you were saying that you wanted some peds questions, so I'm gonna try to do a little bit of a quick round of question. It's supposed to be like a little speed round, but I don't have any timer. I don't have any timer that can beep. Yes, so we'll just take a few few answers first, and then we'll move on. All right. All right, I think I sent it to a few. Oh, you're working on your research project? Okay, nice. Nardia, how are you doing? Welcome, welcome, welcome. So I have, it's like, you know, just a little refresher. Let's just say a little refresher for study tonight. So it's like a quick, we'll try to do some quick answers, and then from there, that will be the end of the live. So, all right, let me turn this, and welcome on YT as well. Welcome, welcome, welcome. I see two persons over here. How are you doing? Remember to go ahead and subscribe to the page. You can also follow me on TikTok and on YouTube at Think Nursing. For the full length of the live streams, they'll be posted on YouTube. So if you miss the live stream, or if you decide to run and go do something, you can always come back and get the full length of the videos on YouTube. And those include anything from cardiovascular, endocrinology, what else we did? We did endocrine, neuro, GI. So go onto YouTube and subscribe to the page so you can actually watch those full length of the live stream. Thank you so much, Betty. Thank you for following, and follow me here. I'll still post one or two of the things onto the platform. All right, so let me turn this thing around so you guys can see the screen. Oh yeah, and remember the heart me's. All right, remember to send your heart me's, claim your points for participating on the live. Let me turn this thing. Let me zoom in. Oh, you're Nurse Betty? Okay, nice. I'm Stacy. Welcome, welcome, welcome. So, that's what we're here for, all right? So, I'm going to try to see if I finish at 9 o'clock. So, I'm going to try to do 1 hour. Let's see if we can do 1 hour. Or let's see how many questions we can do. So, which one is the first one? Well, you know, as usual, we always start by messing it up. Oh, remember to go ahead and share up the live. That would be nice as well. If you could share the live up. Let's do some taps on the screen just to get the live out to other persons who are interested so they can actually come over and join us tonight and the other nights moving forward. Rosie, thank you so much for tuning in. Susie, who else I see? Yeah, just tap up the live, MCT Jazz, Coffee, and Muffin. Because we're not going to remember to tell them to tap up the live. I'm not going to remember because we'll be chatting away. Susie said furosemide. Okay. So, what time is it? 8:04. Please just share the live a little bit. Just share the live, even to two of your friends, two of the persons in your friends list. That's all I'm asking. Share the live and tap up the screen. Can you be my mentor? I'm preparing for NCLEX. Not a problem, not a problem. I'm here, Betty. As I say, go onto YouTube as well and subscribe to my YouTube page over there. And you'll find additional contents, longer form contents that are posted on YouTube. So we will go through some questions here. Sometimes the questions might seem easy, but there's a lot to learn from the questions. So they might not look like your real, like NCLEX, like some persons will be thinking from Archer Review or UWorld, but the content is there. And that is what is most important. So I see here people answering already. Who is this? Natch. I'm going to say Natch. Answering polystyrene. Stop the infusion and call the doctor. Prepare to administer insulin, calcium, dextrose. All right, so client with DKA has potassium of 5.9. Which intervention comes first? So which intervention comes first? So need so you need ECG, yes. So you need ECG. Prepare to administer insulin, calcium gluconate, glucose. Oh, calcium gluconate. Dextrose, Keoxalate, shift insulin. Abby, welcome. Timo. So we're gonna start the infusion, the insulin infusion. So infusion. So the insulin shifts potassium into the cell, urgently lowers potassium. So the potassium is elevated, but even so, the insulin is gonna do its thing as well as so gluconate. Yes, your calcium gluconate. So someone had said stop the infusion and call the doctor. No. So rock. So it's a client with DKA, diabetes ketoacidosis. Their potassium is 5.9. So usually you want to make sure potassium is within that normal range. 5.9 is a little bit elevated, but either way you're going to be giving your insulin. You're going to be giving your insulin, so that is going to shift your potassium into the cell. So it will eventually lower the potassium there. So you're not going to stop the infusion. You're going to start your insulin infusion. And then from there, you continue monitoring. So you start your insulin infusion. Insulin shifts potassium into the cells, and this urgently lowers your potassium level. A patient on digoxin reports yellow vision. The nurse should check which lab. So remember, Keoxalate is going to be orally. That's not going to work anytime soon. So you want to start your infusion. Eventually you can give your Keoxalate, but that is not the initial thing for that patient. So the priority here for this patient is to check your potassium. Okay, so a patient on digoxin reports yellow vision, which is indicating that this patient is toxic. Yes, the levels are high. So the nurse should check which lab. You'll definitely check your potassium, Isaiah. Hypokalemia increases digoxin toxicity risk. So toxicity from hypokalemia, potassium and serum digoxin level, yes. And then you'd want to have your Digibind, Digifab as your antidote for this patient. I see NAC, put Digi beside. Nice. A client with SIADH, what fluid order do you expect? So you have a patient that has SIADH. What fluid order do you expect to give? Isaiah says sodium chloride. Hypertonic fluid, Rose says sodium. What is going on with this patient? What is going on with this patient here? Patient is retaining fluid. Yes. So you have to be very, very careful on the fluid. So you're gonna have fluid restriction on this patient. So I saw someone that said, hold on there. Sodium. Okay, KT, welcome, welcome, welcome. So they have too much ADH. They have dilutional hyponatremia. So they're gonna need a little bit of a sodium. Oh, you were thinking DKA? Okay, no problem. All right, so this patient is going to be on fluid restriction because they have too much fluid on board there. So they're going to be a little bit diluted. Which patient do you see first? Asthma with wheezing, pneumonia with crackles, asthma with no wheezing. So you have, which patient do you see first? ABC, asthma with wheezing, pneumonia with crackles, asthma with no wheezing. CCC, Moni says A, asthma with wheezing, and Rose says A. Choo, why do you say C, asthma with no wheezing? Think about what's going on with your pathophysiology. So between your asthma, look at A and C. So asthma with wheezing means you have little air going in, right? Asthma with no wheezing means what? They're silent. So which one is worse? Asthma with wheezing shows the airway is narrowing, yes. And then airway becomes fully obstructed. No air is moving in is when you have it, no wheezing. Yes, Tidun. There's no air at all. So which patient you'll see first is gonna be your C, the one that has no air going in, your silent chest, because you have airway obstruction there. So of the three, asthma with wheezing, why is the patient wheezing? You know, you have the bronchioles that are constricted. But if it is completely blocked off, you're not going to be hearing anything. It's going to be a silent chest. So you need to rush to that patient first. All right, let's try to get the live tap up a little bit, guys. Please remember to give the video a thumbs up on YouTube as well. And thank you so much for tuning in. Ibrahim, hi. Thank you for the gift. Thank you for tuning in. Remember, if you haven't followed us yet, go ahead and follow me on TikTok here and subscribe to my YouTube page on YouTube. And thank you for always showing up, for the folks that have been showing up over the past couple of weeks. It has been fun. Thank you, Tidun, for the gift. Really appreciate that. All right. So I see, looking for someone to watch to help me through nursing school. For someone to watch. Megan, I'm here. I am here. So definitely keep showing up. All right. Just remember to follow and look out for the live streams. We do show up at 7 p.m. on Tuesdays and Thursdays. Sometimes I'll pop in like on days like this. If I finish my notes on time, I will definitely show up and we can have very, very interactive live streams. All right. Maybe Ibrahim is saying, so with A, there is asthma, but the patient is wheezing. So there is some airway, some air that is going in. It's not completely obstructed. And then C, asthma with no wheezing. It means that the bronchioles are being constricted. So there is no airflow. So that's the one that you'll run to first. C. Atherosclerosis. Okay, we'll add that to the list as well. So tonight we're looking at prioritization, we have delegation, and I have some PEDS question. And it's more like a bit of a speed round as well. So we'll try to see how much we can cover. And then from there, nice. So this one we say is asthma with no wheeze in the silent chest, bronchial. What is going on? Hold on there, I think I'm pressing on something. Okay. For silent chest, airway obstruction, it's an emergency, so you need to see that patient first. The client has chest pain. The patient is also having ST segment changes. It's elevated. Which medication are you anticipating first? 41, psych, 61 and 67. Rosie, welcome, welcome. I see you. So I see here nitro. Let's see, what is that? Hold on there. So nitroglycerin, pull the screen down. Hold on. Let me take this off a bit so I can fix it. I don't want to go too far on. So ST is just like on the EKG, you have like, you know, a little elevation or some changes. So it's like an appearance. That is like from the that is from like the baseline of a normal EKG. So whenever you have that little segment there, that's when you have like, you know, it's like an isoelectric line. So it's usually supposed to be, say for example, flat, but whenever it's elevated, you have that change. So we call it like a ST segment change. All right, let me pull this back over. So let's go through. So you have a patient that has chest pain with ST elevation. Which medication are you anticipating first? So I see here nitro is not going to be the first thing. So we have, okay, so we have nitro oxygen. Pull down the screen, oxygen, morphine, Mona. All right, so think of your Mona, nice. So aspirin, okay, Tara, I'm then thinking along the line there. So aspirin, so you'll do your aspirin. No, we're brainstorming, Brianna. So we'll definitely get your aspirin, because that is going to help with your platelets. So you get that on board, then you can go ahead with other things. So that's going to help with reducing the aggregation there, so it doesn't cause further clotting. Mona is old school and not used anymore. Okay, so the Mona acronym don't go in that order. No, it doesn't really go in that specific order. It doesn't go in that order. So you will definitely go ahead with your aspirin. EKG, you'll definitely need your EKG because you'd have already seen the ST segment changes. They're teaching us that in school now. Mona acronym is your morphine, oxygen, nitroglycerin, and aspirin. All right, they're saying ATI is doing Mona. I know Mona, we still do Mona for patients. You still give morphine, you still give oxygen, nitroglycerin, aspirin. So Mona is outdated. If they're not hypoxic, don't give oxygen. Yeah, if they're not hypoxic, so depending on what is going on, then you will, but you still also want to ensure that their numbers are good. Still want to make sure you're perfusing. So if they're not hypoxic, then you don't add the oxygen to their treatment. ATI is doing Mona. But if a patient is having, like, you know, chest pain, more than likely you'd have to be giving them oxygen, because that is going to help with getting to that area that is ischemic. So you'll still want to add a little oxygen there. So they're teaching circulation, so apply oxygen. Whatever they're teaching, I guess that's what we need to go by for, oh, hold on, for the exam. What's going on here? For the exam, why aspirin, what's platelet aggregation? So Ever is asking, what's platelet aggregation? So aspirin, what is aspirin? Mona is too basic. I just took ATA and they say yes. Yeah, Mona is still gonna be there. It's still gonna be there. So aspirin is an NSAID, not a blood thinner. It just, because of what the action of it, it makes the platelets slippery. Yes, because of the action, it is used a lot of time because of that. It reduces the platelets from, like, you know, sticking together, prevents the platelet from sticking together, which will cause, you know, like clots. So it helps with thinning the blood, but it's not really a blood thinner. So it makes your platelets slippery. So I just do this. Plavix is an antiplatelet. So Plavix is an antiplatelet, so that also helps with the platelet making the blood thin. So it's just the action itself, how the medication actually works, that makes them different. What is angina? Is that angina? If you tell a cardiologist Mona, they will go crazy. AHA 86, chest pain. Chest pain is ST elevation. Yes, STEMI. Oh, so I guess I have to keep on touching this computer. So angina is the pain, yes. So angina is the pain. This would be like a STEMI, like ST segment changes, MI, because of the ST elevation. Okay. So you'll go ahead with your aspirin. We use nitro for stable angina, definitely, but you have to find out, get the EKG first. We don't just go ahead and put nitro under the tongue because the patient is having chest pain. You have to make sure that the EKG is done first. You can whatever. So yes, but for testing purposes, not for work for a cardiologist doing stress tests. We use nitro for stable. Oh, okay. Lithium level of 1.9. What do you do? So you have a patient with a lithium level of 1.9. What do you do for that patient? Is this lithium level normal? So lithium 1.9 is elevated, critical, yes. What do you do? IV fluids, that's high, it shouldn't be over 1.2. We remove it from the blood. Hi Phantom, how are you doing? Administer antidote, okay. So the lithium level is elevated. Hold medication, notify your provider. We want it to be anywhere below like 1.2, 1.5. So administer your antidote, call your physician. Yes, so depending on what is going on, Then from there, so just make sure you know your reference range for your medications, or your lab values rather. Hold those and let physician know, but NCLEX doesn't test on levels anymore. I see where persons are saying that they've gotten questions with on NCLEX with the range. So I don't know what is going on now, but I've seen persons saying that you have to still know the range for your NCLEX, for your lab values. So just be familiar with them. Just be familiar with them, and then from there. No, there is not really an antidote for lithium. You just have to stop the medication and hydrate. Basically, treat symptomatically. Hydrate, monitor the kidneys, you know, their lab values and all. If it means that the patient is so toxic, or the damage from the lithium is so bad, sometimes they end up getting dialysis. So you just have to treat the patient symptomatically. Whatever is going on with their lab work, you try to correct that. Hydration, things like that. Okay. Thank you for the gift, Phantom. Welcome, welcome, welcome. And guys, remember to tap up the live, share it with the live as well. All right. Well, let's do that. Oh, a patient with myasthenia gravis is drooling, weak and bradycardic. What crisis type is that patient in? So you have a patient with myasthenia gravis, is drooling, weak and bradycardic. What crisis type is that patient in? Choo-choo says cholinergic. I wonder if Choo-choo's on my board. Princess says anticholinergic. Cholinergic. Okay, nice. So yes, this patient is in cholinergic crisis. Too much medication, so they tend to have the sludge symptoms. What sludge means? The mnemonic. What does sludge stand for? That is one way for you to know the cholinergic symptoms or the effects of the cholinergic drugs. What the sludge stands for. That is a very, very common mnemonic for your cholinergic crisis. Okay, can't see, can't spit. So salivation, lacrimation, urination, defecation, GI, affect talking. Okay, yes. What the E stand for again? What the E stand for in sludge? Eating, so sludge. But that is a very, very common, but everything basically increase. So you have salivation, lacrimation, urination, diaphoresis, GI upset, so they will have cramping, diarrhea, vomiting, nausea, and the E stands for emesis. Nice, Amora, thank you. So remember that mnemonic, because you might find this question on the NCLEX. So too much meds, they get the sludge symptoms. A neuro patient has fixed and dilated pupils. What's your priority? What's your priority for that patient? You have a patient that has fixed and dilated pupils, but this is a neuro patient. What is your priority for this patient? I see Narcan. Princess says Narcan. Do we have anybody else? So you have a patient. What would be your priority? I need an 86 on my finals to pass. Pure Chi, chair, welcome. Elevate head of bed, monitor GCS. Decrease ICP. Okay, intubate to airway. Okay. So let's use the airway breathing circulation and try to see. So this one called the provider, sign of herniation, late neuro emergency. So neuro assessment for AMS, okay. Elevate out of bed, neuro assessment, protect airway, called provider. So you have a neuro patient here. You assess them, they're fixed and dilated pupils. The priority, called the provider. So that's a late neuro emergency. Narcan monitor respiratory status. So it depends, because Narcan is for your opiate overdose. So it depends on what is going on with the patient. If you know that the patient had gotten, like, you know, Narcan, not Narcan, any form of opiate, then you can be like, okay, then we can go ahead and do the Narcan. But if it has anything else to do with, you know, anything outside of that, the Narcan is not going to help. A COPD patient becomes drowsy at 4 liters of oxygen via the nasal cannula. What's your concern for this patient? So you have a COPD, a patient who is now drowsy. The patient is on 4 liters of oxygen via nasal cannula. What is your concern, or why are you concerned? So Princess says respiratory distress. Call the provider. Their decreased respiratory or depressed respiratory system, decrease to 2 liters, their over oxygenation, CO2 retention, too much oxygen on board. Yes. So this patient is having CO2 narcosis. Marie, yes, elevated CO2. So you want to go ahead and reduce that oxygen amount. Elevated CO2 hypoxic crisis. So CO2 retention there. So high oxygen suppresses the hypoxic drive, hence why the patient is drowsy. Hypoxic crisis. Yes, TME, welcome, welcome. A client with pancreatitis has Gray Turner sign. What is Gray Turner sign? What is Gray Turner sign? What is Gray Turner sign? Discoloration in the flank area. Yes, so ecchymosis, bruising, anything looking like that. What does it usually indicate? Ash says bleeding, question mark. So what does it indicate? So when you have your Gray Turner sign, what does it indicate? GI bleed. Okay, nice. Usually bleeding, hemorrhage, anything like that. All right, so you have a client with pancreatitis who has Gray Turner sign. What is the action here? So it's a sign, it's a clinical sign for retroperitoneal bleeding. So usually patients who have pancreatitis tend to have it, or sometimes patients have it from trauma. Yeah. So call the provider, NPO surgery. Call the provider. So you have the client with pancreatitis and is now having the Gray Turner sign. The action is to notify your provider. It indicates retroperitoneal bleeding. So you want to make sure that patient is now prepped. Hopefully that patient would have been NPO from before because of the pancreatitis. So we're resting that pancreas. And then now you just get your paperwork ready for surgery until, you know, the doctor comes. So you can get your regular blood transfusion, consent form, all of those. You can prep the patient ahead of time. So by the time they get to see the patient, all of those will be ready. So INR of 6.5 on warfarin. What do you expect to give? You have a patient who is on warfarin. Their INR is 6.5. Is that INR normal? What's the normal INR you're looking for? What's the normal INR? Princess says no. Nice. So 2 to 3 is normal INR. Emilio, welcome, welcome, welcome. So what do you expect to give? Because this is high. What do you expect to give for this patient? Vitamin K. Nice. So yes, so this patient is at risk for bleeding. So you want to go ahead with your vitamin K to help with that elevation in their INR because of the warfarin. Get them to start clotting a little bit. A patient with sepsis has a blood pressure of 78/40. What fluid you'll be giving this patient first? So you have a patient with sepsis, blood pressure 78/40. What fluid you'll be giving this patient first? Normal saline. Why normal saline while a wild sniper? Why are you giving this patient normal saline? Girlie says D5. Dilute the infection. Okay, it's compatible with the blood. Sarah, welcome, welcome. Okay, so for normal saline, for your septic shock, fluid resuscitation is very, very important. Yes, isotonic is always, you know, good. Mountain Dew. JD Vance. How are you doing? Welcome, welcome. So you start off with your normal saline for your septic shock patient. So basically resuscitate them with the fluids. Why you're good, you're good. Wouldn't you want to use LR because it's less acidotic? Why always try anything that I would say you do the LR for your burns patient. But for your if it's just regular, you know, you want to get back volume, just think of it, isotonic is similar to your blood. So always start with that first, and then the scenario never really gave anything to do with, you know, the acid base for this patient. So I wanna go with the LR first. That's what I was thinking, and I have more minerals that can help. Okay. Yeah, but remember ISO means, you know, the same, equal. So it's the same, almost the same as your blood. So always start with that one first. Because sometimes the patient don't need that much. They just need a small amount of fluid just to help with building back up their blood pressure. Or to help with perfusion. Thank you for the gift, Diamond. Thank you. All right, let's go on to this question. NG tube suddenly stops draining. What's your first action? So you're with your patient. The patient has an NG tube. You went to the nurse's station, came back 1 hour later. You realize that, you know, it's not actively draining. What's your first action? Remember, it stops draining, girly. So you can't clamp it. So it says NG tube suddenly stops draining. What's your first action? Stop suction, reposition decline, check for kinks. Okay, nice. So assessment. Always assess your patient, the equipment, everything, and then from there check equipment K with the multiple stars. Nice. So check for kink, pause. Diamond, pause and do what? Yeah, so you want to assess the patient, check for blockage, check with the equipment first. Nice. Check suctioning. Okay, assess and check what's going on. So basically, yes, you'll go ahead and start with assessment. So you assess the patient, you check your equipment, make sure there's no kink, and then from there you move on to doing other things. So the first action is to reposition. Most common cause is usually the tube tip is shift. So check placement. Okay, Keegan, thank you. So check placement, then flush. Okay. So the first thing you'll do, reposition, assess your patient, and then from there. A client with suspected meningitis, what is your priority action for this patient? You have a patient that has suspected meningitis. What is your priority action? Call the provider. Remember, think of it. You're with this patient who is having meningitis, or they suspect meningitis. What is it that you can do? What is the priority at that time? Your precautions. So you want to protect yourself, the patient, and everybody else in that hospital. So your precaution, get that patient isolated, put on, the mask, get the patient in a negative pressure room, things like those. So isolation. Why am I thinking along TV? Droplet precaution, yeah. I was saying negative pressure, that's for your airborne. So you want to do your precautions. So get that patient isolated. That's the first thing you'd want to do. No, droplet precautions, choo-choo. Droplet precautions. Oh, contact droplet, okay. So that's the first thing. Droplet precautions, and prepare for a lumbar puncture before antibiotics for lab work. Yes. And then you'll anticipate all the other things that will be coming. Your lumbar puncture, your antibiotics, blood work, things like that. And as I say, when you're thinking along the line for your answer, always think about safety. Think about safety. Safety for the patient, safety for yourself, safety of the staff or whoever is around. Just think about safety, and then from there, if you're able to think about that, you address that. If they ask about the priority, you try to address that. Just join in. Lorena, welcome, welcome. So, a client with spinal cord injury at T4 has a pounding headache and bradycardia. What's your priority for this patient? You have a client with spinal cord injury at the T4 level, and they're having a pounding headache and bradycardia. What is going on for this patient? Choo-choo says autonomic dysreflexia. Okay, nice. Let's see. Saini says airway. Cervical stabilization. Meningitis. Temptation says meningitis. Okay, so Ash is saying, do you do practice exams for pathophysiology cardiovascular? So yes, I already did some questions for pathophysiology. You can go onto my YouTube page at Think Nursing, one word. I have live streams there from 1 hour up to probably like 3 hours that we were doing before on TikTok here. So you can, just go through them. I'll still create additional content as we go along, so we can still build on our pathophysiology and all. So I did cardiovascular, respiratory, GI, all of the high yield, those, what you call them, the major areas for your NCLEX. So you can actually just play them and listen to the questions as we go through. Not a problem. I haven't started teaching any subjects as yet, just doing questions and try to just dig deep, or let's just say comprehensive studying. It's Think Nursing, so it's the same as the handle here on TikTok. One word. Do you prepare for RE/NR? Michelle, welcome, Wagwan. So I think the questions here are gonna be helpful for the RE/NR exam. So I'm not only preparing for NCLEX, but eventually it's something that will be very useful in the real world as well. So I'm a patient, T5, abdominal clinical pain plus chronic migraine. Oh, okay. So for this one, I think I'd seen some persons that said the autonomic dysreflexia earlier. So the YouTube name is Think Nursing, one word, Think Nursing. So autonomic dysreflexia, goodness, tongue twister, trigger. So go ahead and check the bladder for distension. T4, upper paralysis like arms and diaphragm. Okay. Check for full bladder, constipation, wrinkle sheets. All of those can trigger autonomic dysreflexia. Puncture of the dura mater. Okay. Pneumothorax. Let me see. Sarina. Pneumothorax. I don't know. I'm gonna have to probably put a question mark beside the pneumothorax, unless you're able to explain it a little bit. But I'm not thinking along that line. Oh, the question. So Suk Sidhu, welcome. All right, so that's the question. A client with a spinal cord injury at T4 has a pounding headache and bradycardia. Okay, so check for bladder distension. Autonomic dysreflexia is triggered there, so you want to go ahead and do that. Hypovolemic shock. What finding shows improvement? So you have a patient that is having hypovolemic shock. What finding shows that this patient is improving? How do you know that your patient is doing well after you've started treating them for hypovolemia? How do you know your patient is doing well? Improved blood pressure. Hi, Drippy. Welcome. Regular pulse. Hemoglobin. All right. Remember, the patient is having hypovolemic shock. So, lactic acid levels, okay. Increase output. You say increase urine output. But the blood pressure, what finding? Improved vitals, not dehydrated anymore. Yes. So the patient has improvement in their volume. So skin condition, okay, increased vitals. So all of these are good. But if you're supposed to narrow it down and make sure you're looking, you know, at when you think about the pathophysiology behind hypovolemic shock, narrow it down to one thing and look at like your blood pressure, your urine output, anything that has to do with volume. All right, so making sure that the patient is perfusing properly. So your blood pressure, so increased urine output, kidney perfusion is returning. So the patient is now producing urine. So you know that things are looking good for the patient. What is it that you're expecting in terms of the urine output? What's a good number for your urine output per hour that you're anticipating to say that this patient is having normal urine output? 30 mils per hour. Nice. Okay. So better skin condition, better heart rate, blood pressure. Okay, patient tachy at 116. Continue abdominal pain plus continuous migraine. Huh. So the patient is tachy at 116. Continue abdominal pain plus continuous migraine. I'm reading your answer here, Jennifer. I don't know what we're talking about there. So distal pulses are stronger, meaning blood pressure is perfusing strong. Thank you for that, Strawberry Wish. Welcome. Depends on the weight. Yes, everything is going to be based on their weight. Patient receiving blood develops itching and hives. What's your next step? What is your next step? So you have a patient that develops blood, develops itching and hives. What's your next step? Stop the infusion, notify the MD, stop. Yes, keep normal saline going. So you want to stop the transfusion. The patient is having an allergic reaction. So you stop the infusion. What else are we doing? So I know we said that, okay, somebody says draw 0.3 epi, okay. Safety, run normal saline. Are we running through the same line or different line? Epistat. Stop access call. Exam. Nice. Give normal saline. Different line. Yes. What do we do with the blood? Do we throw it in the bin with the red bag? What do we do? Mohammed, welcome, welcome. Send it back to the lab. No, send it back to the blood bank. Definitely. Okay. Who this? Give it to the, the vampire. JD, welcome. Again. Oh Lord. You're the one with the Mountain Dew. Yeah, so you send it back to the lab so they can always go ahead and check it. That's what I mean. Yeah, no problem. OG Sasha. I know we're typing fast, so I can't pick up 1 and 2 little typo error. What's a reason that they're reacting? So me and River is asking, why are they reacting to it? Why are they reacting to the blood? What are some different reasons why patients develop reaction to blood? Incompatibility, yes. It's not a match for them. So is the blood bad? It's not necessarily say the blood bad. It's just not compatible with the patient. It was not cross-matched. So they never check it to say, okay, then this patient and this, you know, both blood can go together. Because sometimes, especially if you have it under like emergency, you're giving blood under emergency situation. Sometimes there's a risk for incompatibility because it's not always cross-match. But a lot of times, you know, it's pretty safe when they need to test for the blood type prior to administering. JD Vance, yes, they do. But sometimes depending on, they will get the universal blood and transfuse. So sometimes those patients, the blood might not be compatible to the patient. But they do check for compatibility. You do send off blood ahead of time and they send it, but things do happen. Nurse gave the wrong blood, not double check, things like that. Yeah. So there are so many different things that can cause, you know, a person to develop a reaction to it. But either way, we just need to stop the blood, send it back, figure out why that had happened, and then from there prevent, you know, prevent recurrence of it. You can also check if they've been allergic before, and that's another thing, yes. And all of these you'll capture on, like, you know, the consent form as well. If they've had blood transfusion reaction before, that usually will help as well. I'm not in nursing school, I'm just an EMT, but I enjoy learning more. Not a problem, and giving trouble as well. Yes, you're making the live, you know, the folks here smile a lot because I see you with your Mountain Dew and the vampire story, and you know, so it's a little bit of a mix in the live here. Baseline vitals and monitor for 15 minutes. Yes, so if the blood is going fine, once you hang the blood, you stay with the patient for 15 minutes and monitor, and then from there, same, I'm in pre-med though. Okay, no problem. So you keep on monitoring the patient, and once you're there and you realize that the patient is developing some form of reaction, you just stop it, then you notify your provider, and then per protocol, you go ahead with your medications. Okay, congratulations on starting the LPN school. Okay, which electrolyte imbalance causes U waves on the ECG? Yes, Dayton, wrong type of blood they're getting. Thank you so much for tuning in on YouTube there. So which electrolyte imbalance causes U wave? U wave on the EKG. So hypokalemia, low potassium, yes. Yes. So I know, so I want you to say whether or not it is high or low. So yes, your hypokalemia, hypothermia, New Jersey nurse, welcome. IPO, nice. And which one would give you the T? Okay, which one would give you the T wave on your EKG? Oh, so hyper. Okay, new journey says the T wave from early. Okay, nice. So your hyperkalemia would give you your T waves. Nice. So hypokalemia is the one that gives you the U wave, and hyperkalemia will give you the peak T waves. A trauma patient has paradoxical chest movement. What's the diagnosis? You have a patient that is having paradoxical chest movement. What are you thinking in terms of diagnosis? What is going on with this patient? So it's a trauma patient that comes in with paradoxical chest movement. What is going on with this patient? Let's see. Okay, not looking for that. Mohammed, I'm not looking for that. Princess, Choo. No, I'm not looking for paradoxical. Paradoxical. I see everybody saying pneumonia. Hematomas, no. Sternum and rib cage detachment. Nice, JD Vance. So if the sternum and the rib cage is detached, you have in your flail chest. Yes, Kevin, welcome, welcome. DY says rib fracture as well. Nice. So that's how you'd have your paradoxical chest movement. So I think it's what, three or more rib being fractured on the same side. Is it 3 or more? It has to be multiple ribs. So let's look up flail chest. So flail chest, let's book it. OG says, okay. So it is 2 or more adjacent ribs that fractured in 2 or more places, creating a free floating segment on the chest wall. So you have the paradoxical chest wall movement, which is a key sign. They have severe chest pain, dyspnea, cyanosis that is going on. This paradoxical movement reduces effective ventilation and causes hypoxia. So it's more like a free floating segment of your chest wall there. So it's basically going in opposite direction. So one side is up, the other side doesn't rise and fall at the same time. So tension, some persons were saying tension pneumothorax. Oh, I think it's most pronounced with 4. Okay. Yeah, but it has to be multiple. It has to be multiple. Multiple on the same. So see, it says 2 or more adjacent ribs. Okay. In 2 or more places. But I see a few persons that said tension pneumothorax. What is tension pneumothorax known for? What is the classical sign for tension pneumothorax? Oh, tension pneumothorax that would have deviated trachea. Yes, they will have deviated trachea. Tamponade. They would be hypoxic. JVD, jugular vein distension. All right, so for that would be it for the for your tension pneumothorax, deflated lungs issue, not a rib cage issue. Yes, decrease or no air entry in one side. Yes, Strawberry, I am from Jamaica. Mohammed, so moving on. Too much oxygen and lungs on the other side. All right, so let's go on. Oh, from Guyana. Okay, nice. Mohammed said too much chatting. Next. Oops, it's me. So oh Lord, let me not. Hi, ICP. prevention. What is the correct action? So you're trying to prevent intracranial pressure, increase intracranial pressure. What are some things you can do for that patient? Don't lay them flat, low stimulation, ICP monitoring. Some just simple things that you can do at that time while you're at the bedside. So positioning, keep the bed at 10 to 30 degrees. Yes. So simple things can help with preventing worsening and just help with, venous drainage there. And ventricular drain, mannitol. Yes. What kind of drug is mannitol? What kind of drug is mannitol? No drastic positional changes. Yes. What kind of drug is mannitol? Don't stress them out. Osmotic diuretic. Yes. So osmotic diuretic. Decrease fluid from the brain. And as I was saying yesterday, whenever you have the different diuretics, just make sure you know where they're working. You don't want it to be a case where you have a patient in CHF and you're going to choose mannitol to give to that patient. Yes, they're going to lose a little fluid, but it's not going to be working as effectively as if you're choosing like your loop diuretic or your thiazide. So just make sure you're looking at the question, think about the diagnosis and the mechanism of action where the medication is going to be working. Dextrose can be used too. Dextrose. I don't know about, I know you need dextrose for the brain, but with your, I don't know about the relationship with your intracranial pressure and the treatment for that. You want to remove the fluid, so you go ahead and do your diuretics. Dextrose is sugar, yeah. Glucose. I'm not so sure about the relationship between between that. So let me just look up something. As I said, this is the time we're learning different things, so let's look up. Okay, so let's look at it. So dextrose and intracranial pressure are important to understand because fluids containing dextrose can affect the brain in certain conditions. Effects on ICP, intracranial pressure. Dextrose is osmotically active. When administered IV, it enters the cells quickly, including the brain cells. In patients with brain injury or elevated ICP, giving hypotonic or glucose-containing fluids can increase cerebral edema, potentially raising the intracranial pressure. So no dextrose, because that is going to cause more problems for the patient. No dextrose, have sugar, the brain is not lacking it, just filled with fluids. Hypertonic solutions are good for high. So no, it's not something that you'll give to your patient because it's going to potentially raise the pressure there because of the cerebral edema that will result from it. So the brain cells are very sensitive to osmotic shifts. So hypotonic fluids or fluids that rapidly enter cells can draw water into your brain tissue, worsening cerebral edema. So safe practice for these patients, check your glucose level. Give dextrose only if the patient is hypoglycemic. Monitor neurological status and ICP if fluids are needed. So keep on monitoring these patients when when you're doing your fluids. And even if you're not doing the fluids, you still need to, because the patient has increased intracranial pressure. Yes, yes, that would help. But as I say, if you're thinking about the fluid itself in the brain, you have to find one that is gonna work specifically on the brain. So the mannitol, the osmotic diuretic there will help. Then the albumin will help with preventing the shifting, the third space shifting in terms of fluid. So if they're like hypotensive, if they're hypotensive, if you notice that their albumin level is low, then definitely go ahead and do that. But it's not going to help specifically with your ICP getting that fluid off. All right. So who do you see first here? A COPD patient with 92% oxygen and productive cough. B, post-op hip replacement with pain, 8 out of 10. C, asthma patient who is suddenly not wheezing. Or D, heart failure patient with 2+ edema and crackles. So we see C, 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 B. So C, all right. So the asthma patient who is suddenly not wheezing. We did a question like this earlier. They're not wheezing anymore. That's a problem. They're having a silent chest. So you want to go ahead and look at that patient first. The COPD, a patient with 92%, that is acceptable. So you don't need to run over to that patient. Post-op hip replacement with pain. They're not going to die from pain there. Heart failure patient with 2+ edema and crackles. Sometimes it happens overnight, but that is not going to kill the patient. So the asthma patient who is suddenly not wheezing is the one that is having a severe airway obstruction. So jump to that patient, and then from there you treat. And as I say, a lot of times you might be asking yourself, all of these patients are emergent or they're urgent, but you have to just decide who is going to die first if you don't go over to see that patient. C is going to be that patient. Which client is the highest priority here? I was thinking probably you were looking at embolism there with a post-op patient. Well, you probably chose that one. Which client is highest priority here? A patient with diabetes and a blood glucose of 420 but alert. The client with pneumonia and a respiratory rate of 32. A client with DVT reporting cough pain. And D, a client with PE symptoms such as chest pain, sudden dyspnea. Who is highest priority here? D, 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 D. Airway, breathing, circulation. So your patient with the PE can be very fatal in minutes. So you want to address that one. The diabetic patient here, glucose is high. Patient is fine because the patient is alert. They won't die from hyperglycemia like that. Client with pneumonia, respiratory rate, yes, a little bit, tacky, but they will survive. DVT, cough pain, they will survive. But the PE patient that is having chest pain, sudden dyspnea, use your airway breathing, circulation, and start with the first patient that is gonna require attention there using that mnemonic. That sudden is very important. Yes, and the sudden is very important. So just make sure you're looking at the different words that they're using. Who do you see first or assess first? A seizure patient with tongue bite. B, a stroke patient suddenly unable to speak. C, hypertensive patient with blood pressure 184/92. D, a cancer patient with neutropenia and fever of 100.9. Who do you see first? So I see B, stroke patient suddenly unable to speak, airway, breathing, circulation. If you can't find anything there, address the patient that is having any form of neuro problem. So seizure patient with a tongue bite, okay. Stroke, hypertensive patient with blood pressure 184/92, elevated but won't die. Cancer patient with neutropenia and fever. That's an oncology emergency, but they won't die. This patient here who is unable to speak is gonna be the problem. They could be cutting their airway off. Yes. So your stroke patient who is unable to speak, you want to go ahead and look at that patient, possible stroke. Time is brain, that is very important. Also, if the patient is having a stroke, they might just having, their tongue might causing problem as well. So you want to also look at their airway there. Might just obstruct it. Hypertension isn't that extreme. Cancer patient needs a cancer floor and some antibiotics. So what do you do in that moment? In that moment, all of these patients are sick. All of these patients need you, but you're only one person. Who are you going to look at first? Find out Which patient is gonna die if I don't do something about it? No. So in the first few minutes, a seizure patient who will bite their tongue, is that patient gonna die? No. No. Put an X. Hypertensive patient with a blood pressure 184/92, is that patient gonna die? No. No. Put an X. The cancer patient with neutropenia and fever, is that patient gonna die? No. No. The patient who have a stroke and suddenly unable to speak, that is the problem. So with a tongue bite, they bite their own tongue. Yes, they bite princess. So always just look at it and see who is gonna die first. If you don't do something, who is gonna die first? All right, antibiotic is gonna be for this one. It's gonna be for a few days. You give some medication, blood pressure drop there. The seizure patient bite the tongue, more than likely they're out of the seizure, not actively seizing. So just don't read into the question. Whatever is presented in the question, just work with it. Just work with it. Don't add anything, don't subtract anything. That's just the question. Which patient do you see first? A, post-op thyroidectomy with tingling around the mouth. B, post-op appendectomy, wanting pain meds. C, pancreatitis patient with radiating back pain. D, pneumonia patient with loose cough. Who do you see first? Who do you run to first? All of them are important, but which one is gonna grab your attention because you don't want that patient to die on you? I see A, C, C. Okay, so A is a post-op thyroidectomy with tingling around the mouth. And then I see a lot of person says pancreatitis patient with radiating back pain. So you have the thyroidectomy patient, the tingling, they remove the thyroid gland. So you're having the hypocalcemia because of that. They're having hypocalcemia because of that. So they're having the tingling around the mouth. Yes, thyroid storm. Okay. Night shift healthcare. Post-op appendectomy patient wanting pain medication. We'll get to the pain medication. They won't die because of not getting the pain meds. So put an X beside that one. Pancreatitis patient with pain radiating to the back. What could be happening with this patient? Yes, it is expected. It is expected for them to be having the tingling sensation. But at the same time, you need to get, yes, they might have a rupture of the pancreas. So you need to make sure we get some, get that patient some treatment for that thyroid, the tingling, the hypocalcemia, because remember that they've removed their parathyroid gland. So that patient is gonna be needing those medication to treat the low calcium there. Post-op patient is expected pancreatitis. It's very painful anterior and pneumonia. So the hypocalcemia and laryngeal spasm. So just think of the fact that airway might be compromised if you don't address that tingling sensation there as well. Priority patient here, diabetic with a blood glucose of 60 but responsive. B, trauma client with rigid abdomen. C, migraine patient with photophobia. D, kidney stone patient crying in pain. Who do you see? Who is your priority here? So diabetic with a blood glucose 60, trauma client with rigid abdomen. C, migraine patient with photophobia. C, B. Okay, so just remember airway, breathing, circulation. This patient is a trauma patient. So what are you thinking here for this patient? They're having internal bleeding, strawberry wish. Nice. So rigid abdomen, usually for trauma patients, you're thinking internal bleeding. So you go and see that patient. Even though the blood glucose is 60, this patient is responsive. So you don't need to be like, rushing too much to say, okay, let me go and see that one first. No, not bacteria in the abdomen. More than likely it's blood. So that would be a part of your circulation, airway, breathing, circulation. So if you don't see an airway problem, you don't see a breathing problem, there is a circulation problem. So address that one. Migraine patient with photophobia will survive. Kidney stone patient crying in pain. Yes, it's very uncomfortable, but they will still survive. Round trip to the OR for exploratory laparotomy. Nice. So just use your airway, breathing, circulation to still answer your question. Who is priority here? Post-op patient 3. Post-op day 3 patient with mild fever, 100.4. B, chest pain patient with diaphoresis. C, asthma patient asking for second breathing treatment. D, flu patient with dehydration. So airway, breathing, circulation, if you find it there, we have B, chest pain with diaphoresis, yes. So you go ahead and address that patient. Post-op day 3 with mild fever, it's expected. C, asthma patient asking for second breathing treatment. The fact that they're asking, airway is still good. C and D, flu patient with dehydration will survive. So the one that you need to address is your chest pain with the diaphoresis there. Active chest pain is possibly MI, so address that patient and save the heart. If not, that patient is gonna die. Which client do you see first? A, alcohol withdrawal, patient with tremors. B, patient with C. diff diarrhea. C, patient vomiting blood. D, post-surgical patient with no bowel sounds. So who do you run to first? All of them, but which one do you choose? Airway, breathing, circulation. Are we able to find that? I see a few persons says C, patient vomiting blood. Okay. C, okay. Temptation says A. So the GI patient, risk for hypovolemic shock. So you always use your airway, breathing, circulation for that. If you're able to identify an airway problem, breathing, circulation, then you're good. If you're not, then you go on to your Maslow. Your Maslow hierarchy of needs. You can also use your ADPI, your assessment, diagnosis, planning. For your alcohol withdrawal patient with tremors, that's not an emergency. Like, not really an emergency, but it's expected when you're withdrawing from anything to be having some form of tremors. So that patient is not really the one you'd want to see first. Patient with C. diff diarrhea expected as well. Post-surgical client with no bowel sounds. That is usually expected. Just make sure you're monitoring because of the medications that the patients would have gotten. So the patient vomiting blood, this one is a circulatory problem. So you want to ensure that you address this patient. If blood coming out, we're going in. Nice, Ashley. I love that. D is expected with anesthesia. B is not life-threatening and D needs attention but not crisis, definitely. So C is the answer for that one. Who is the highest priority here? A new diabetic dizzy after insulin. B, new confusion in elderly patient. C, COPD, a patient with wheezing. Or D, a CHF, a patient with pink frothy sputum. So who is your highest priority? All of them is important. All of them are priority patient, but who do you address first? Airway, breathing, circulation, look for those. And then from there, so see A, B, A, D, B, okay. So new diabetic, dizzy after insulin, hypoglycemia, okay. New confusion in an elderly, COPD patient with wheezing, expected, so we're marking off C. CHF patient with pink frothy sputum, we're gonna say D, pulmonary edema, airway and oxygenation. Remember, use your airway, breathing, circulation. If you can't find any answer there, then you move on to neuro. If there's a neuro answer, you choose the neuro one. But first, it's airway, breathing, circulation, then neuro. If you can't find it there, do your ADPI. If you can't find it there, use the Maslow hierarchy of needs from physiological up to safety, and you find your answer. So D, the CHF patient with pink frothy sputum. It's an airway and oxygenation problem. So you go ahead and address that patient. As I said, the COPD patient, the wheezing is expected. The new confusion in an elderly, keep an eye on that patient. The new diabetic dizzy after insulin is expected if if the patient is hypoglycemic. So that's not really, you'll put an X beside that one. So you're choosing between D and the confusion. Just look back at airway, breathing, circulation. If there is nothing there to address that, then you go on to the confused patient here. So D, then B. Then I would say I would go to A. And yeah, I would go to A, then C. So it depends on how you want to address the remainder. Which patient needs immediate attention? A burn patient with hoarse voice. B, a cancer patient requesting pain meds. C, a post-op patient with 10 mils per hour urine output. Or D, a diabetic patient with blood glucose of 500. So which patient needs immediate attention? Airway, breathing, circulation. A. I see one person says C and then D. All right. Okay. So a burn patient with hoarse voice. What we know about a patient with hoarse voice? Not a good thing. Let's go down to cancer patient requesting pain medication. So treat each answer as a true or false. A cancer patient requesting pain medication. Is that patient going to die from not getting pain meds? No. A post-op patient with 10 mils per hour urine output. Is that patient going to die? No. Yes, we know that patient is not getting out enough urine. But, the patient can wait a few more minutes. Diabetic patient with too much glucose on board. Will that patient die? No. Put an X there. Put an X at C. And go back up to the patient with the hoarseness. All right, that's a big airway problem. So get your ventilator close by. Get your patient ready to be intubated because of that burn injury. All right, so that patient requires immediate. So you're dropping everything and run to that patient because of that inhalation injury there. So anytime you see burn patient, hoarseness, yeah, make sure you're looking at the people in the mouth. All right, looking at them nose as well. Okay, and then from there, so hoarseness after burns, airway problem, don't play around with those patients. So sometimes they might be walking and they look just like you and I, but then you hear their voice. Yeah, man, find a bed and put them somewhere because that patient is gonna be your immediate patient at that time. Who do you see first? A client? Kidney failure patient with potassium of 6.3. B, patient with seizure 10 minutes ago. C, patient with fever 101. Or D, a post-op patient with moderate drainage. Who do you see first? We're going to see all of them, but which one are you going to drop everything and run to? The kidney patient with potassium of 6.3. Kidney failure. Patient with seizure 10 minutes ago. A patient with fever won't die. Post-op patient with moderate drainage. Who are we going to be running to? We know the potassium here is high. This patient is at risk for arrhythmias. So you want to go ahead and address that patient. All right, the risk for fatal arrhythmias. So address the patient that has high potassium. And then from there you can go on to see anybody else. So a patient with seizure 10 minutes ago. 10 minutes ago, patient is probably stable. All right, probably sleeping. Just make sure in terms of safety. Patient with fever will need some Tylenol, Motrin, whatever it is, tepid sponge bath. Post-op patient with moderate drainage expected, but this kidney failure patient is problem. Left, right, and center. Normal potassium 3.5. Kayexalate is not going to be for immediate. So if you're supposed to be choosing your medication, that is going to cause, you're going to have a diarrheal effect, but it's not going to be working. You're going to have to wait a few hours or a few minutes before that starts working. So you want to start your IV medication. What medications are you looking for? Astasia, Brown. What are you going to be using to treat your potassium here? D50 insulin, glucose. Nice. What are we going to be using to protect the heart? No, we're not going to give no banana, JD. We are going with banana. We are going with banana. So for immediate treatment, so this patient is in front of you. What is it that you need right now to get that potassium down in the next 15 minutes? Calcium gluconate. Nice. So you need a calcium gluconate, insulin, glucose. Put the patient on a cardiac monitor. Make sure you get your IVs. And then from there, yes, you can also use your albuterol inhaler. Your Kayexalate is going to be orally, so it's going to take a few hours. So if you're in the exam and they say, what is the first thing? Do not choose any oral medication because we know that it's going to take some time before it start working. All right. Hi, Chang. Wagwan. So, yeah. So, all of those are additional medication, but the ones that you need immediately are going to be anything IV. And the salbutamol, yes. Do not give them bananas or potatoes. Nice. Which client is priority here? A COPD patient on 2 liters of oxygen, sat in at 89%. Post-op patient with sudden chest pain. C, stroke patient with slurred speech 2 hours ago. Or D, abdominal pain, patient with nausea. Which client is priority? Airway, breathing, circulation. And then from there, address everything else. Who do you see? I see BBB, post-op patient with sudden chest pain. Okay, new onset. Yes. So Blue Lagoon says or. C or B. You have to make up your mind. You only have one answer in the exam. It's the chest pain. So airway, breathing, circulation. And then from there, airway. So COPD patient on 2 liters, the SpO2 is normal for that patient. So put an X beside it, not priority. You have your post-op patient with sudden chest pain. You're thinking about a clot. So put a tick beside this one. The stroke patient with slurred speech 2 hours ago. If you're looking at the airway, breathing, circulation, neuro, you have to address airway, breathing, circulation problem first. Then if you don't find anything there, you go to neuro. So you're going to put a tick beside this one. Abdominal pain, patient with nausea, put a X beside. So you're choosing between these two, B and C. Airway, breathing, circulation, which one will come first? Your chest pain patient here. And then you can address your stroke patient later on. Respiratory therapist here, shout out to my nursing students. You can do this. So there is, I don't know. Yes, abdominal pain with nausea is pretty normal. So you don't need to run and do anything. Slurred speech resolved. So probably TIA. Nice. Yes. COPD is sometimes 89 to 92% for their SAT. Good. So the sudden chest pain, MI or PE, immediate action is needed for that patient. Who do you see first here? A patient with pancreatitis and vomiting. B, a diabetic patient with blood glucose 45 but is awake. C, asthma patient with respiratory rate of 40 and retractions. Or D, post-op patient needing IV antibiotics. Who do you see first? A, the patient with pancreatitis and vomiting. I see C, the asthma patient with respiratory rate of 40 and retractions. And the same thing again, airway, breathing, circulation. You go with your respiratory problem here. C, severe respiratory distress, airway risk. Patient with pancreatitis and vomiting is not going to die if you don't address that patient, no. B, diabetic patient with 45, it's hypoglycemic, but the patient is awake. So you can just grab something and give this patient to eat in the meantime. Won't die. Asthma patient, the post-op patient needing IV antibiotics, won't die from not getting the antibiotics in the next 15 minutes. So you jump onto your asthma patient here with a respiratory rate of 40 and it's having retraction. This patient is in severe respiratory distress. So go ahead and address this patient, then you can run on to the other patients from there. So retractions is accessory, must be used, respiratory failure imminent. Definitely temptation, nice. Priority patient here, a patient with heart failure gaining 3 pounds overnight, a client with hypertensive crisis 210 over 110, C, a client with UTI and fever 101, or D, a client with broken wrist. Who is your priority patient here? BB, they are post-op though right after, okay? So who is emergent? Who is your priority? I see A, then B. Okay, so we're gonna go again with airway, breathing, circulation, and then from there. So you have a patient with heart failure gaining 3 pounds overnight. Would you rush to that patient? No, that patient more than likely sitting up watching TV. So you don't need to drop everything and run to this patient. A client with hypertensive crisis, blood pressure of 210 over 110. More than likely this patient start having chest pain and all of the 9 yards with it. So make sure you look at this patient first. The client with UTI and a fever, yeah, febrile, will address this patient, won't die. A client with broken wrist will still survive another day. So your hypertensive client here is more than likely having some dizziness, headache, chest pain, you know, a bunch of things going on. So drop everything and rush to this person. And then you can go to the other patients, because a lot of these are, if you're having heart failure and you're not taking your medications, and even if you're taking your medications, more than likely you'll be gaining some weight as well. Your UTI, a lot of times you'll be having your fever, you just treat it, and then from there. I wish these questions were in my NCLEX. They're more like, yeah, they're more like, you know, just to study. You just have to understand the content and then put it into practice on the exam. All right. So hypertensive crisis, remember you're thinking about your stroke and end organ damage risk. So you address that patient first. Who should the nurse assess first? A, the patient with pneumothorax with tracheal deviation. B, anemia patient with a hemoglobin of 7. C, dehydrated child with sunken eyes. And D, the patient with nausea after morphine. Who do you see first? Who is it that you're going to drop everything and run to? I see A, and then I see beauty nurses C, the dehydrated child with sunken eyes. Okay, and then I see who? Taya. So let's go again. Remember, airway, breathing, circulation. If it means you're going to write it on every question, well, you're not going to write on any paper, but just make sure you write it down somewhere. Airway, breathing, circulation. Then you can go to neuro and then everything else. So who do you assess first? Do you see an airway problem in any other patients that they present there? Do you see breathing or respiratory? Or do you see a circulatory problem? From you look at this one here, is this an emergency or is it somebody that we can send home and tell to come back another day? So not because it's a child, it doesn't mean that because it's a child, it doesn't mean that because the person is screaming the loudest or they're telling you that their pain is 100 out of 10. It doesn't mean that that's the person you're actually going to be running to. Think about what is going on in terms of the pathophysiology and see who will die if you are not taking care of that patient or treating that patient immediately. So you have a patient with pneumothorax who is having tracheal deviation. That's an emergency. If you don't address that patient, no, that patient is going to die. The anemia patient, yes, but the patient will survive another day. The dehydrated patient with the sunken eyes, yes, we need to get some fluids on board, but I don't think that patient is going to die if you don't, get to that patient, no. And the patient with nausea after morphine is expected, so we're going to mark that one off. So we're going to mark off B and D. If we're supposed to be competing between the two, A and C, which one will you drop everything and run to? All right, you run to your tension pneumothorax because immediate airway collapse. So if you don't address that patient is 6 feet under. Let's just see. So go ahead and address the tension pneumothorax. Then you run over to your, you run over to your dehydrated child and get some fluids pushed in. And then from there, why would it be D? The patient with, I don't know, but dehydrated patient, they will tend to have the sunken eyes. So that is expected, but even though it's expected, they will crash out very fast. They will crash out very fast, so you have to keep an eye on them. But in terms of airway, breathing, circulation, you have an airway problem here. Then the dehydrated patient will be C. So it's going to be under circulation. So that's the third patient. Let's just say if you were supposed to have an airway breathing ABC patient on here, that would be the third patient you will see. So it's always going to be airway breathing, circulation. And then if you can't find anything under each of those, you look for a neuro problem. You look for a scenario that is having some mental, like, you know, with the patient having some mental status changes, and then from there. All right, so YRN says not always though. Okay, why you say that, YRN? Michelle is asking, is this live every day? So I go live on Tuesdays and Thursdays, and then depending on if I finish my notes, I will try to pop on for an hour, which seemed to be an hour and a half. No. Eliminate expected find. Yes, not always, like in critical care. Love your accent. Thank you, Lorena. Class tore me up. If they have an airway problem that is expected with the problem, then yes. So that's the other part of it. If you realize, so for example, you have a COPD patient and they would normally have like shortness of breath, that is something that is expected with them. But what if you notice that this patient who is having worsening shortness of breath, probably a little bit of a mental status change, but or, you know, in terms of hypoxia, then you would address that patient first. So if it is something that is chronic, but if you have acute changes, then that changes the game. So you have to just make sure that you understand the pathophysiology behind what's going on, and then from there. Oxygen sat to be like 95 is normal. No, you want it to be anywhere between 88 and 92 for your COPD patient. Who would you see second, B or C? So who I would see C, the dehydrated child with the sunken eyes. I would see that one. So airway, breathing, circulation. Yeah, I would see this. I would see C. I would see C first. 95 to 100 is normal patient. Tension pneumothorax is an emergency. Yeah. What's a normal hemoglobin? What's a normal hemoglobin for female? Why not A? A is the correct answer, Ness. The patient that you'll see first is A, the tension pneumothorax patient. And then I would see the dehydrated child with the sunken eyes. Then I would see B, then D. What's a normal hemoglobin for your female? Why is C the second priority? I would choose C just because it's a circulatory problem. I know anemia, yes, anemia patient with, but just because it says child, I would go with that one. You never really give anything much in the answer B. It just says anemia patient with hemoglobin 7. C says dehydrated child. So if I'm supposed to choose between an unknown patient and the one that they give me, the child, the age, then I would go with that. That's just how I would look at it. So around 13 to 18, so it's going to be higher for your, so 12 to 14 for your female, it's going to be a little bit higher for your men because of the muscle. Is that because children often decline? Yes, so because children decline so fast, I want to, you know, hang around and say, all right, let me go and do a anemic patient, hemoglobin there, address that. I will try to address that dehydration first and then from there. 14 to 16 for male. Yeah. Pneumothorax and tracheal deviation is an emergency. Yes, they are. Which client is a priority here? A, appendicitis patient with right lower pain. B, pregnant patient with bright red vaginal bleed. C, COPD patient requiring frequent suctioning. D, patient with heart rate of 55 on metoprolol. So which patient is your priority here? A, appendicitis patient with a right lower pain. B, a pregnant patient with bright red vaginal bleeding. C, COPD patient requiring frequent suctioning. And D, a patient with heart rate of 52 on metoprolol. C, A, possible rupture. D, B. B on a beta blocker is fine, okay. So D, we're gonna put an X beside D, all right. Patient with a heart rate of 52. Yes, we know it's low, but the patient is on a beta blocker, so you're expecting the number to be on the lower side. Appendicitis patient with right lower quadrant pain. Okay, that's expected in your appendicitis patient. So now we're looking at your COPD patient requiring frequent suctioning. That's not an emergency. So you're left with your pregnant patient here with bright red vaginal bleeding. So that's the one you're thinking about. Bright red vaginal bleeding. What is going... Oh, I showed the answer already. What is going on here is a placental abruption or previa risk. So fetal and maternal emergencies. So that patient you need to run to first. All right. So pregnant patient with bright red. And if you look at it again, airway, breathing, circulation, this patient would be the first patient just because it's circulatory. She may be losing her baby. C is expected too. I had B and the ambulance came quick. Oh, I'm so sorry to hear that, but happy that everything went well, Candy. Placenta abruption. What do we know about placenta abruption? What is this patient having pain or no pain? With your patient with abruption, is this patient having any form of pain? Do these patients reports that they're having pain? I see pain, pain, pain. So is it painless or is it painful? No pain. Just think about abrupt. It's painful. So if you look at placenta previa and placenta abruptia, so just think of abrupt. If something rips apart abruptly, you're tearing something, you're gonna have some pain. All right, previa is the one which doesn't have the, so previa is the one that is painless, abruption is painful. So that's one way to remember it. So if the patient comes in and they're having a lot of pain, bright red vaginal bleeding, you're thinking about placental abruption. If they are having, bleeding, no pain, then you're thinking about previa. All right, so just think about that, and then from there, abruptio is dark red, yes, and then the previa is bright red. Who do you see first here? Painless patient, sepsis map of 58. B, patient with flu and dehydration. C, a kidney disease patient with edema. D, a diabetic patient with a blood glucose of 370. Who do you see first? A. Okay, nice. I see Lorena says D. Good Lord. D. You're going to see D, Candy? The diabetic patient? Everybody else saying A. The patient with sepsis of map of 58. What are you looking for in terms of the map? Or why did you choose A? Is it because it says sepsis, or are you looking on the map? Which one did you look at? So are you just thinking, were you just guessing? Okay, so a lot of persons are looking at the map. All right, nice. So you're looking at the mean arterial pressure of 58 here, which means that there's a perfusion problem going on. So you want it to be over 60. Or 65. 65, map of 65 or greater. So the map is low, so you want it to be above 65 to know that the patient is perfusing well. So this patient more than likely is a little bit confused, a lot of things going on because they're not perfusing well. So who do you see first? Airway, breathing, circulation. Patient with flu and dehydration, not an emergency there. Kidney disease with edema expected. Diabetic patient with 370 glucose expected. But the patient with sepsis, blood pressure low, MAP low, problems for you. So you want to go ahead and see this patient first, then you address every other patient. But sepsis, shock, you don't want to be dealing with that right now. So you go ahead and get that patient well perfused with some fluid. Patient B, because don't let the body get dehydration. Yes, yeah, so the patient, but even if you look at it from a circulatory problem. If you have two circulatory problem, are you concerned about the person with the flu and the dehydration, or the one that is having sepsis going on with a low MAP? That's normal if they have flu, yes. So always look at it and just think of who is gonna deteriorate fast, who is gonna die first, things like that. Patient D, ASIO is asking, you'd go and see patient D? The patient is just hyperglycemic. You have some patients, if they're at 330, if they're at 370, they're probably, you know, hypoglycemic at that stage because their body is just accustomed to their glucose being high. So you can't just assume they are shocked with a MAP of 58. No, you cannot. You have to use other variables to help with that. Because you have some persons who are, you know, their MAP is fine. Their MAP is a little bit low. They're still perfusing well. So you're not going to use only the one thing to determine that, Miles. Over 400 to 500, possible DKA. Okay. But then you have to think of making sure that you have ketones as well. Risk of kidney failure and other organ issue. Yes. So who do you see first? Just think about the pathophysiology behind and then what is going to be happening and address that patient. So the patient with a MAP less than 65 is showing poor perfusion. So you want to go ahead and address that patient first. Which client needs immediate attention? A, the patient with fever 103 after surgery. B, double vision in Guillain-Barré patient. C, post-op patient with no pulse in the right foot. Or D, the asthma patient asking for an inhaler. So which client needs immediate attention? A, the patient with a fever of 103 after surgery. B, double vision in a Guillain-Barré patient. C, post-op patient with no pulse in the right foot. Or D, the asthma patient with asking for the inhaler. So Sikea Butter says C. Good night, Michelle. Thank you so much for joining in. D, then C, asthma patient asking for inhaler. Okay. Oh, this is hard. Yeah, this is a reality sometimes. So you have to choose one. So, okay. So I see a few persons saying D, asthma patient asking for inhaler. You have your fever here. Patient who has a fever of 103 after surgery. You have a double vision patient with Guillain-Barré, and then you have your post-op patient who has no pulse. So remember, still use the airway, breathing, circulation, and then from there, even though this asthma patient is asking for the inhaler, just think of airway, breathing, circulation, and then from there. So this one is a little tricky. So the asthma patient, it never really says that is, you know, it's given that this patient is wheezing, asking for the inhaler. But with the post-op patient here, no pulse, you know, you're thinking about an amputation there, because if they're not having any pulse going on, no blood flow, then that is a problem. So, but the asthma patient here, who is going to die first? I know we say airway, breathing, circulation. This one is still tricky for me. If the patient is asking, then it means that the patient is not like dying. So you want to save the limb for this person. So I would go with the C here, all right? Because this patient is asking, which means the patient is not like, say, severely distressed. So you can always go ahead and address this no pulse here in the right foot. And then you come back to your asthma patient. So airway, breathing, circulation. So even though you have your airway, breathing, circulation that we keep on saying that is what we're doing, you can still, depending on what is going on, if this is not something that is emergent, you'll just go on to the other one. The high fever after surgery is normal. So high fever after surgery or fever after surgery is normal because then the body is going to eventually, you know, things are going to start reverse, and then you can always do your fluids to help with bringing that down. It's just the body's way of responding to whatever procedure they did. So it's not like a dire, like, you know, it's not something that is going to hurt the patient. So that patient can wait. But this one, you want to save the limb of this patient. Answer D doesn't have enough info. Remember not to read into the question. Yes, YRN. Thank you for that reminder. And then from there, so you can always just look at the question and see if it is something that will hurt the patient or not. But just put your X beside that one. The post-op patient, you want to save this limb. They're not perfusing properly. What is Guillain-Barré? What is Guillain-Barré syndrome? What is this? What is Guillain-Barré? What do we know about Guillain-Barré? Or Barré, some person says. It's an autoimmune disease. So muscle weakness, yes. So a lot of times they tend to have muscle weakness that is caused by the attack on their immune system or their peripheral the peripheral nervous system there. Exactly. Can affect the respiratory system. Yes, because you have the weakness. Dr. Pink in the house. Can cause airway and respiratory failure. All right, so this patient was having what, double vision. So want to be like your highest high risk of diaphragm muscle weakness. I think I've seen this probably 1 or 2 times. I've never really treated any patient with that. It's normal for Guillain-Barré. Okay. Priority patient here, a new confusion in elderly on antibiotics. B, pneumonia patient with a respiratory rate of 22. C, DKA patient with fruity breath. Or D, a heart failure patient with 3+ edema. Who do you see first? Who is your priority? The new confusion in elderly on antibiotics. B, pneumonia patient with respiratory rate of 22. C, DKA patient with a fruity breath. Or D, heart failure patient with 3+ edema. So A, toxicity. A, new onset sudden is priority. D, Kussmaul respirations, that's normal. Okay. Is it the Kussmaul or the ketones here? The fruity breath. Because of the ketones. So the heart, so this is pretty normal for them to have the fruity breath because of the ketones there. It's not Kussmaul. So the Kussmaul has to do with their breathing. So the DKA patient with a fruity breath is because of the ketones. So that is normal. Heart failure patient with 3+, that is pretty normal. So you want to rush to that patient. Pneumonia patient with respiratory rate of 22. Okay. New confusion in an elderly patient here on antibiotics. You're thinking about like delirium or anything like that. So go ahead and address airway, breathing, circulation, then neuro. So we don't find anything that is, you need to rush to. Then you go ahead and just address your neuro patient here. So the delirium patient, sepsis or neuro decline, address that patient. So just remember, new confusion. So they're treating this patient who is on antibiotics now. So probably a UTI or something that has been causing all of this confusion in the patient. So anything that is new onset confusion is usually delirium. Who do you see first? The kidney stone patient screaming in pain. Don't let this word frighten you and let you choose it and be like, okay, running all over the place. But who do you see first? The kidney stone patient screaming in pain. COPD patient with thick sputum. C, the burn patient with 10 out of 10 pain. Or D, new onset chest pain unrelieved by by rest. So D, I see C. Jerry says C, the burn patient with 10 out of 10 pain. All right, so pain is never a part of the airway, breathing, circulation first. All right, so try to go with your airway, breathing, circulation. Kidney stone patient screaming in pain is a pain problem. COPD patient is a respiratory problem. Burn patient is a pain problem. New onset chest pain unrelieved is a circulation problem. So you go ahead, airway, breathing, circulation. You have your new onset chest pain, you'll address that one. It's unrelieved by rest. So you know definitely that is something cardiac. All right, so possibly MI going on. Pain is going to be a part of your Maslow hierarchy of needs. So that is going to be a part of the last set of things you're going to look for in the scenarios here. All right, and then from there. So who do you see first? D, unrelieved chest pain, active MI, risk. So new onset chest pain, unrelieved by rest. That's the patient you're going to be seeing. COPD patient with thick sputum, expected burn patient with pain. Yeah, they're going to have a pain. You want to address them as well. Kidney stone patient screaming in pain, definitely address that patient. Myocardial infarction, heart attack, purple circle. Why not B? Airway is blocked. So COPD patient with thick sputum, if you were supposed to, if you have two patients in front of you, you have patient B and D, and you have a patient that is having chest pain, who is gonna die first? Who you think will die first? Is it the patient that has too much sputum, or is it the patient that is having chest pain? So who is gonna die? The thick sputum, that one is not gonna die, you know, so you don't need to rush to that one first. You need to go ahead and address the person who's having that heart problem. Where did it say airway is blocked? It didn't say, it just says that COPD patient with thick sputum. So the patient will be fine. Don't read into the question. Don't read into the question. It says thick sputum. We don't know whether or not this patient is swallowing the sputum. We don't know whether or not the patient is spitting out, you know, looking at, we don't know. It just says thick sputum, and we're just going to work with that. New onset chest pain unrelieved. You just work with that as well. Tell B to turn, cough, and deep breathe. Exactly. You have to just prioritize all of the patients that come in front of you, even if them have a corn on them too. It's going to be an emergency. It's going to be an emergency to the patient. It's going to be priority. But who is going to survive the next the 15 minutes that, you know, if they're supposed to be waiting, who will survive? Who can survive? So start with your airway, breathing, circulation. If you find one, address that problem. That is going to be your priority patient. If you can't find any patient that matches airway, breathing, circulation, then you move on to neuro. Which client is priority here? A patient on warfarin with an INR of 4.2, the patient with C. diff, diarrhea, the patient with angioedema after ACE inhibitor, the post-op patient with 100 mils drainage an hour. So which client is priority here? The warfarin patient that is elevated INR. Okay, so I see C, I see A, then I see D. All right, so the post-op patient with 100 mils drainage an hour, we're gonna tick that. That is okay. The patient with C. diff diarrhea, that is normal, so we're gonna tick that. We're gonna mark them off. Which the patient on warfarin INR 4.2 is at risk for bleeding. But if you look at patient C, angioedema, this changes the game for this patient. This patient's airway is a problem. So you have to stop everything, run to this patient, and get them started with, you know, medications to help with that edema there, because they're not gonna get any air in. So you have obstruction going on here. You have to stop and address this patient. So as I say, you'll use your airway, breathing, circulation. So airway is obstructed here, or in the process of. So address this angioedema, then you can decide to address anybody else from there. So your patient in C is airway obstruction, angioedema, so you go ahead and see that person first. Then you can think of going to see who else. Patient on warfarin with INR 4.2, even though the patient is on, you know, the INR is 4.2, the patient is not bleeding out, so you have still little room to wiggle around. Patient with C. diff diarrhea is expected. And then you have your post-op patient with 100. So you can choose anybody from there and see. So the post-op patient with 100 mils drainage an hour. So it depends on what is going on. I would say you could go and see that patient, the post-op patient. Then you can go and see your C. diff diarrhea. depending on how much they're putting out. Okay, because it says this patient warfarin INR, so the patient is at risk for bleeding. Go and see that one as well. It didn't say what is draining. No, it didn't. But it says post-op, so we're just gonna think that probably, I don't know. We'll just keep it at 100 mils, whether or not it's a chest tube, whether or not it is. So I would go CD, CD, probably B, CDA. I'll probably do CDA, B. Yeah. But C is the most important one there. Do they give the formulas for those calculations, or do we need to memorize them? Oh, you have to know them, ASIO. I just read it fast. 12 hours fresh post-op. Okay. Yeah, you have to do it. You have to something there. You have to know your calculations, your dosage calculations and all, if they're gonna do that on the exam. Who do you see first here? A hyperthyroid patient with heart rate of 130. B, the patient with asthma who cannot lie flat. C, stroke patient with sudden right-sided weakness. Or D, heart failure patient with coughing at night. So who do you see first? Hyperthyroid patient with a heart rate of 130. B, the patient with asthma who cannot lie flat. C, the stroke patient with sudden right-sided weakness. Or D, heart failure patient with coughing at night. I see B, brain is, time is brain. And then I see A, hyperthyroid patient with heart rate of 130. Okay, so, and then I see C, so C. All right, so a lot of persons say C, so we're gonna put a tick beside that one. Let's go with airway, breathing, circulation, then neuro. So if you have a hyperthyroid patient with a heart rate of 130, is that something that is expected for that patient? So even though the heart rate is elevated, what is the pathophysiology behind hyperthyroidism? Is that something that is expected? Do you need to rush to that patient? No. So we're going to put an X beside that one. The patient with asthma who cannot lie flat. Yes, the patient is asthmatic. You have bronchoconstriction going on. So you don't want to put that patient. Prop that patient up. The patient will be fine. The patient won't die. Heart failure patient with coughing at night expected. So not going to rush to that one. So if we're looking at B and C, the asthma patient who cannot lie flat and the stroke patient, which one of them is going to deteriorate fast? Which one of them will die first? I know the asthma, you have the constriction, but the stroke patient with sudden right-sided weakness, you want to make sure that brain is good. So you want to see that patient first, and then from there, you can address your asthma patient. So we'll go with C, possibly ischemic stroke, must act fast, and then from there. So you have this patient coming into you. What are you anticipating? So MRI is going to be later on. You definitely need your dry scan. You're going to need your MRI, but that's not going to be your initial. You're going to need your CT scans to determine whether or not it is ischemic versus hemorrhagic. So your CT scan is going to be very, very important. What is TPA, Melanexo? What is TPA? Because I don't know what TPA is. And Jamie's saying the same thing again about TPA. What is TPA? I'm going to come with this fancy Neiman. What is TPA? Altiplace. I see clapbuster, thrombolytic, clapbuster mid. You only have time. EEG. No. Okay, so I think we're doing thrombolytic, and then somebody is saying plasminogen. No longer use TPA, we use TNK. Okay. Some hospitals have been using TNK for a while. But what is TPA? What TPA stands for? Because I know we're always writing it. Thank you, Arku. Thank you. Tisoplasminogen activator. Okay. Now, yes. So you have the 60 minutes to give apixaban or aspirin loading. Nursing school still teaches altiplace. Yeah. Head to toe, eyes, not by, not recommendation. Tissue something. Yeah, it's a tisoplasminogen activator. I know a lot of times we tend to be saying it, but we don't remember exactly what it is. So I just want us to kind of type it out like we're doing it in the exam. Yes, so the window is 3 to 4 hours. What are some contraindications for doing TPA? What are some contraindications to giving TPA? Only given in ischemic stroke. Okay, nice. So what are some contraindications for not giving TPA? Active bleeding, recent surgery, in that 3 months, hypertension or hypertensive crisis, bleeding, previous blood thinner use. I can't see the question, sorry. Hemorrhage. Hemorrhaging. Okay. Yes. More than 4.5 hours from the last known well, low platelet. And then it depends on, because if you have some patients that are very large, then they have consideration up to 24 hours for like the thrombolytic. So it depends. INR greater than 1.7. Okay, nice. So at least we know GI bleed and all of those things. So this patient would be your patient that you'll see first. So this patient comes in. What if this patient was having the right side, you know, they were having slurred speech and you are there with the patient. The patient is having slurred speech. You're thinking that the patient is having a stroke. What is it that you definitely need to get for this patient? You're getting their vital signs. What is one thing that you need in their vital signs at the time when you're seeing this patient? Okay, so we get a patient. We're going to get a patient to CT. But in terms of their vital signs, what is something that you definitely need to get outside of blood pressure, temperature, heart rate? Okay, neuro, no. Yeah. Okay, I'm not seeing it. So you have this patient, blood glucose. Thank you, Austin. Thank you. You definitely need to get your glucose on this patient, okay? Because sometimes you might have hypoglycemia that is masking. And so you might miss out on hypoglycemia, and then we're doing, not saying that they're not gonna, not all the time they do scan the brain, because if the patient is having things going on just the same, they will still. But you would have to get that glucose as well. So this is a bad question. You give the answer away with sudden. Oh, yeah. You said it. Now I'm saying, yeah, as a part of their vital signs check. I was just trying to narrow it down a little bit so you can actually try to go into the glucose. Jerry, sorry. All right, so let's go on to, because these are the things that makes the like, these are keywords for NCLEX, I think. So you have to just look at each question and look at the words that they're using, hyper or hypo. Why glucose? Why glucose is important? Why you have to check glucose for your patients that having stroke-like symptoms? Why you need to do your glucose check for those patients? Diamond is asking. Hypo, too low, confusion. Hypoglycemia can mimic a stroke, okay? So they might have similar symptoms. So sometimes this patient might just be unresponsive. They might have the slurred speech. You know, they might have the facial droop. So the symptoms are similar. So in order to identify or rule out, you have to get their glucose to see that they're not hypo or hyper. Glycemic, lethargic, sudden, yes. So B is, no, not B. B is not the answer. C is the answer. So the patient here is going to be your stroke patient with sudden right-sided weakness. Same like hemiplegic migraines. Money Q, welcome, welcome, welcome. C, yes, AJ. Who is the highest priority here for this patient? A hypoglycemic patient who is confused with a blood glucose of 50. B, post-op patient with abdominal distension. C, the patient with high potassium but stable. D, the child with asthma and wheezing. Who is your priority patient here? Let's see, A, B, D. Okay, let's look at B and D. So hypoglycemic patient, confused, blood glucose of 50. All right, so we're gonna keep this one. Post-op patient with abdominal distension. Can put an X beside that one. Not gonna rush to that one like right now, I think. The patient with high potassium, but stable. Hold on there. So we're gonna do airway breathing circulation. So the post-op patient with abdominal distension. Abdominal distension can be because of different things. It's a post-op patient, can be internal bleeding. It can be just because of the anesthetic drug. So we'll put a question mark beside. Patient with high potassium but stable. This patient is at risk for arrhythmias, but they said the patient is stable, so we're assuming that EKG looks fine. Child with asthma and wheezing expected. So the highest priority here is going to be your confused patient. Let's see what they have here. Your confused patient. Just because your post-op patient, as I said, this can be expected from your post-op patient. C, the patient with high potassium, but the patient is stable. That's fine. Child with asthma and wheezing expected, but your hypoglycemic patient, this patient is now confused. So neuro-wise, you have to see this patient because this patient is at risk for coma. So 70 to 110, why not D? Child with asthma and wheezing. If you have a child with asthma and wheezing and you have somebody that is hypoglycemic and confused, who will you go and see first? So even though we're using airway breathing circulation, the child with asthma and wheezing, is that person like, someone you have to like rush to right away? Will that person die? Or in terms of deterioration, what we know about hypoglycemia, what we know about the brain not getting enough glucose, what is going to be happening? So if you're supposed to choose between your asthma and your asthma patient wheezing and the patient that is hypoglycemic, and you're thinking about the pathophysiology, this patient is already confused, the glucose is low, so you want to go ahead and address this patient. Not shock, Alice, not shock. So it's not always airway. So even though sometimes you might look at it and you see where it says an airway, just find out if it is normal for whatever condition it is. If it is something that is not life-threatening, you don't need to address that one. You're going to find out which one is going to cause this patient to die, which one is going to complicate things. So even though, yes, asthma is an airway problem, it's not going to be that one because the child with asthma, it didn't give you anything else regarding what's going on. It doesn't give you anything else that is going on. The high potassium, yes, we understand that that patient is going to be at risk for arrhythmias, but it says that the patient is stable. The post-op patient with abdominal distension, just think about when you have your post-op patient, you might have the distension because of the anesthetic, that they've been using. The patient has been open up for a while, but you have your hypoglycemic patient that is confused. Everything else is not that important right now. Your coma patient is going to be priority. So your coma patient is going to be priority. So even though we're saying airway breathing circulation, just make sure, because I know sometimes we might say, because it's a airway problem, the first airway question we see, we go ahead and just choose that one. But it might be an airway problem that is stable, so you don't need to rush to that patient first. So A is a disability. Yes, confusion is a big issue. They can be at risk for death very quickly. PhD, it is correct, though hypoglycemia and confusion is the highest concern. Yes, that is the problem there. Eden is asking when the live ends. It should have ended about 2 hours ago, Oh Lord. So tonight was just a pop-up live. It was just a pop-up live. I was gonna just do 1 hour, but we end up here for how many hours now? A few hours. So ABC, but make sure the symptoms are not common with the concern. Yes. So make sure whatever is going on. So even though you might have an airway problem, if it is something that is not gonna cause a person, any harm, or it's not going to cause the patient's situation to deteriorate even more, you don't need to rush to that person first because it's expected. So like just like your UTI patient, they might have fever. Yes, we need to address it, but you don't need to rush to that person first. What is it? So ABC, but make sure the symptoms are not common with the concern. Yes. If you go unconscious, you risk losing your airway. Exactly. Thank you, Austin, for that one as well. So the answer it's A. The answer is A, the confusion. So you have an hypoglycemic patient. The patient is confused. This patient is heading into the coma. Remember the glucose here is 50. So this patient is at risk for coma. So you have to address this patient. So even though, as I say, A, B, C is not always, because not everything. You have some patients that have chronic things going on. So even though you have your COPD patient and the patient might have been having shortness of breath, the shortness of breath is not something that is new. If you're having worsening shortness of breath, retractions, things like that, anything that is acute, then that makes the situation different. And wheezing has a simple intervention, and likely a bronchodilator will be difficult to address. Okay. So 70 and lower blood glucose, please can we move on to the next? Yes, Barbara, but remember there, persons are still talking here. So that's what the live is about, trying to make sure everybody's comfortable with what's going on. Not how ABC is used. Okay. So the answer is A. All right. Which client should the nurse assess first? Who are you going to drop everything and run to first? Is it... No, Ali, you wouldn't give them juice. That patient is confused. Patient is hypoglycemic and confused. If they're able to talk, then fine. If their airway is good, then you can always give them. But you want to go ahead and... depending on what is going on. So the patient is confused. If the patient is lethargic, then you wouldn't want to risk giving that patient anything because of the risk for aspirating. So which client should the nurse assess first? A, the patient with peritonitis and rigid abdomen. B, the patient with COPD on 3 liters of oxygen via nasal cannula. C, the patient with dehydration and dry mucous membranes. D, the patient with mild chest discomfort. So which patient will the nurse assess first? I see A. No, it's ABC. All right, so look at airway, breathing, circulation. The patient with peritonitis and rigid abdomen, what we know, what is going on here? This is an emergency, okay? We'll go on to patient with COPD on 3 liters of oxygen. Is this okay? Yes, so you put an X beside. You want to run to this patient. The patient with dehydration and dry mucous membrane, that is expected, so you don't need to rush to this patient. The patient with mild chest discomfort, the patient is having chest discomfort, mild, but you have a patient here with peritonitis and rigid abdomen. What is going on? You want to go and address that patient with the rigid abdomen because of the risk for shock from sepsis, because the peritonitis. What is going on in peritonitis? Inflammation of the abdomen, nice. So you want to go ahead and address that patient first. Then you can come and address your mild chest discomfort. It's mild chest discomfort. You want to get this patient to the OR. This is a surgical emergency. So what's going to kill the patient first? So this one you want to go ahead and address. Save all of those organs there. That is probably that is perforated. Inflammation of the peritoneum, ruptured inflammation. Angina won't kill you. Sepsis is very likely and very quick to kill the patient if not treated. Increase intra-abdominal pressure. So yeah, go ahead and do that one. I believe it's inflammation of the peritoneum, the abdominal cavity. Yes, the peritonitis. So you want to go ahead and address this problem here. Patient, how are you sure it's angina and not STEMI? So you don't, you have to have your ECG to tell whether or not it's a STEMI. Okay, you only can see it on the EKG. And angina is a pain. But you have to see the ECG changes, that ST segment changes, the elevation in order for you to say it's a STEMI. And then you get the blood work as well. You get the blood work as well to look. So for example, the EKG is normal. You don't see the ST segment changes on the EKG. But when you do the blood work, you see the elevation in their troponin. Then that is going to tell that this patient is having a non-ST segment elevation. Non-STEMI, non-ST STEMI. Yeah. Oh Lord, what time is it? So that's how you'll tell the difference between the STEMI and the NSTEMI. So your priority patient here, to see first, A, heart failure patient with orthopnea, B, patient with pulmonary embolism symptoms, C, post-op patient with pain, 6 out of 10, or D, nauseated pregnant woman. So who is the patient that you'll see first? Airway, breathing, circulation. I see AAA. It's an easy B. Okay, nice. You have a heart failure patient with orthopnea. Is that expected? Yes. Post-op patient with pain, 6 out of 10 won't die. Nauseated pregnant woman won't die. The patient with the PE symptoms is the problem. That one is at risk for death. So you want to go ahead and address that patient first. It's caused by blood clot. That's super dangerous. You're going to go for B. Yes, so always think of it. Which one will send the patient 6 feet under? Which one will? And this patient here, just think about what can happen with your PE and then from there. Ali says, I'm so smart. I know, Ali. Welcome, welcome, welcome to the Smart People Corner. PE can lead to cardiac concerns. Blood clot in the lungs, yes. Tachycardic feeling of sudden death, B. Okay. Who is priority here? A patient with fever 100 on 100.9 on chemo. B, the patient with JVD and crackles. C, the patient with anxiety and tingling hands. Or D, the patient who hasn't voided in 8 hours. So who is priority? The patient who has a fever of 100.9 on chemo. B, the patient with JVD or jugular vein distension and crackles. C, patient with anxiety and tingling hands. Or D, the patient who hasn't voided in 8 hours. So B, jugular vein distension, pulmonary hypertension. Donnie says D, the patient who hasn't voided in 8 hours. Will that patient die? The patient gone 8 hours. Will that patient die? Let's put a question mark beside that one. Patient with anxiety and tingling hands can wait. The jugular vein distension, put a question mark beside that one. The patient with fever 100.9 on chemo is an oncology emergency, won't die, but who is gonna be your priority patient? A patient with jugular vein distension. What is going on here? Patient having too much fluid on board. So the patient that is life-threatening is your neutropenic patient, your oncology emergency here. So let's go on to who is priority. The jugular vein distension crackles with your heart failure patient or your chemo patient of 100.9. So B is just your too much fluid, which is expected for your heart failure. Anxiety and tingling won't die. Patient who hasn't voided in 8 hours won't die. So you want to treat your neutropenic patient, which is life-threatening. So that fever on chemo is the one that you'll go for first. Why would it not be A? It is A. The answer is A. The answer is A, Anna. The chemo patient, it's an oncology emergency. So that one is going to be A. C, wrong answers only. Okay. So all of these are, this one is Is expected, expected. The anxiety, tingling hands, not an emergency. Hasn't voided in 8 hours, won't die. Just the bladder is going to be a little bit more distended until you get this one sorted out first. 100% when I saw this based off personal experience. Okay, they teach us in ATI fever is 101.4. Yes, Sasha. Which task can the RN delegate to the UAP, which is your unlicensed assisted personnel? Fever is common in chemo, but then what is the number you're looking at for your fever? You probably can have like your low grade temperature, but if it's gonna be fever where it's 100.1, 100.4, then that's gonna be a problem. So which task can the RN delegate to your UAP? Teaching a patient how to use an incentive spirometer. B, monitoring a patient 1 hour after giving opioids. C, feeding a stable stroke patient with right-sided weakness. Or D, assessing a new admission. So the answer here is, I see A, teaching a patient how to use an incentive spirometer. Okay, is that something that you can delegate to your UAP, your unlicensed assisted personnel? The answer is going to be you're feeding the stable patient with right-sided weakness. So it's a stable stroke patient, which means the nurse would have already done their evaluation, done their dysphagia screen, and established that this patient is able to be fed by somebody else who, just like a relative. Yes. Teaching a patient how to use an incentive, this is going to be, your initial teaching is going to be your RN. It's going to be your RN duties. So the registered nurse is going to have to do this. Teach the patient how to use the incentive spirometer. And then you have your LPN who can always go ahead and re-educate or teach, but it's not the initial teaching. Your UAP, just think of your layman, so they're unlicensed, so you won't give them anything like that to do. Monitoring a patient 1 hour after giving opioids, assessment. You still need to do that as your RN. Your LPN also can monitor your patient after medications. C, feeding a stable stroke patient with right-sided weakness. So we established that this patient doesn't have any problems with swallowing. So you can give this person to your UAP. Assessing a new admission is going to be the primary responsibility of your RN. So respiratory assessments after opioid administration, yes. They can't teach or evaluate, no. As an LPN, I do and I've done all of the above. So then again, it depends on, so LPN. Yeah, so, well, I don't know where you're doing the teaching. Sometimes things happen. But reinforcing, how to use the incentive spirometer would be a responsibility of you, the LPN. But the initial teaching is going to be your primary RN. So UAP may assist with feeding if the patient is stable and no aspiration risk. Which task is appropriate for your LPN? Administering IV push morphine. B, completing an admission assessment. C, giving oral antibiotics to a stable patient. Or D, developing the care plan. So which task is appropriate for your LPN? C, nice. Administering IV. LPNs cannot do IV. They can do IM injections. Completing an admission assessment. That is your admission. So that's going to be your RN. Giving oral antibiotics can be given by your LPN, your RN. Developing the care plan is going to be your RN. So out of all of these, giving the oral antibiotics to a stable patient is the one that you will give to your LPN. So LPNs can give PO medications to stable patients, no IV pushes, no initial assessments, no care plans. Per NCLEX, C is correct. Yes, C is the correct one, the oral antibiotics. What can the RN delegate to your UAP during a code blue? A. Start compressions. B. Document the code. C. Defibrillate. Or D. Administer epinephrine. Which duty can the RN delegate to the UAP during a code blue? The answer is going to be A. Start compressions. Why? Because everybody is trained how to do CPR, right? Everybody is trained how to do basic CPR or BLS. So starting the compressions is something that they can do. Document the code is going to be for the RN or the primary nurse. Defib is going to be for your RN or whoever else is trained to do so in the room. Administer your epinephrine is the same thing for your RN. So your UAP can start your chest compression just because they're certified in CPR BLS. Registered nurse, Sunalika. Okay. Which task can be delegated to the UAP? A. Checking the NG tube placement. B. Measuring output from a Foley catheter. C. Hanging a new tube feed. Or D. Changing a sterile dressing. So which task can you delegate to your unlicensed assisted personnel? B. Nice. Measuring output from a Foley catheter. So checking the NG tube placement, that is going to be for your RN and your LPN as well, because they do NG feed as well, so they can reassess, but the initial assessment is going to be your RN. Hanging a new tube feed, your RN. Changing a sterile dressing, your RN. So A, C, and D is going to be for your RN. Checking the NG tube, hanging the new feed, yeah. So all of those are going to be for your RN. UAP can measure output but cannot assess, insert, or manage the tubes. Which task can the LPN perform? A. Titrate vasopressors. B. Reinforce teaching about insulin. C. Perform initial wound assessment. D. Evaluate a new onset of chest pain. So C. Who is this? Quisa? Quisa says C. Perform initial wound assessment. So this is the problem here. Initial. So perform initial. Anything to do with initial is going to be your RN. All right. So titrate vasopressor medication, RN. Reinforce teaching about insulin. Reinforce is the LPN. They can do that. Evaluate a new onset of chest pain assessment. The nurse is going to have to do that, the RN. Perform initial wound assessment, RN. They can reinforce after RN teach the first. Yes. Yes, UAP can document how urine output looks like. Okay. So LPNs can reinforce, not initiate teaching. The RN is delegating to the UAP. Which task is appropriate? A. Ambulating a post-op patient for the first time. B. Feeding a patient with dysphagia. C. Performing daily weights. Or D. Checking pain level. So the RN is delegating to a UAP. Which task is appropriate? C. Performing daily weights. So ambulating post-op patient for the first time. You want to assess the patient there. So that's going to be your responsibility, the RN. Feeding a patient with dysphagia. You want to check to see if this patient is able to swallow. Jacinth, how are you? Yes, C. Performing daily weights. That is something that your UAP can do. Checking pain level is assessing the patient's pain. The RN is going to do that, okay? So D is LPN. Yeah, LPN or RN. So C, the UAP can collect routine measurements for the patients. Unlicensed assisted personnel. Mansoor, welcome. B is speech therapy, RN. Yes. So the answer is C. Means CNA when referring to UAP. Okay. So Lotius says NCLEX always means CNA when referring to UAP. They can ask about it, but they just can't document it. They can ask about anything, but they just can't document it. They can ask about the pain, but they just can't document it. What can the UAP do? A. Apply oxygen via nasal cannula per RN order. B. Perform a sterile wound dressing change. C. Provide post-mortem care. D. Administer enoxaparin. So what can the UAP do? CCA. Okay, what is this? LPN can't do central line IV blood transfusion. No, they can't, Barbara. Okay, so we have UAP are not trained to do sterile dressing. No. That's going to be your LPN. They're able to. So CC, I see A here. Apply oxygen. Oxygen is a medication. So can your UAP do that? No. And it depends on where. Yes, Luminous. It depends on where you're at. Because here in the States, you have different states that, you know, and the facility as well. So depending on the state and the facility, but in general, what is the standard? I think that is what NCLEX wants you to be aware of. What is the standard? Because when you get to some facilities, there are certain things that they might ask the LPN to do, or certain things that they'll ask the UAPs to do. So it depends. But what is the standard for CNAs, UAPs, RNs? In the NCLEX world, they just want to know that you know the right thing to do. So apply, what can the UAP do? Apply oxygen via nasal cannula per RN order. No. Perform sterile wound dressing change. No. Provide post-mortem care. That is something that, you know, a lot of us tend to do. And D, administer enoxaparin. So the answer here is C. They can do comfort care tasks like bathing and post-mortem care. A, UAP can do. No. They cannot, even though per RN order, no. So even though it's like 2 liters of oxygen via nasal cannula, the RN needs to put it on. So NCLEX is all about making sure that everything is safe for the patient, for you, and everybody else that is around. So they want the right person. They want you to know that the right person is doing the right thing. Which task can be delegated to the LPN? A, teach about anticoagulant side effects. B, administer IV potassium. C, conduct a nursing diagnosis. Or D, perform tracheostomy care on a stable patient. So which task can be delegated to the LPN? Teach about anticoagulant side effects, administer IV potassium, conduct a nursing diagnosis, or perform tracheostomy care on a stable patient. Yes, Anna, D is correct. Kawasi says A. All right, remember it says teach about. Most of the time you'll see they use the word reinforce for if you're talking about the LPN doing education or teaching. So teach about anticoagulants. That is going to be the initial role, the role for the nurse there. So D is the one that is going to be most appropriate. Performing that tracheostomy care, because conducting a nursing diagnosis is going to be your primary care, your nurse. Administer IV potassium, LPNs can't do. Teach, initial teaching is going to be your RN. So LPNs do not teach, they reinforce. In Massachusetts, LPNs teach. I don't know about the other places. In general thing, as I said, depending on where, yeah, admission, discharge, teaching, all of those are responsibility for the nurse. Which assignment is appropriate for your LPN? My school did IV, but it did not delegate in there. Okay. Which assignment is appropriate for your LPN? A newly admitted patient with sepsis, a patient receiving blood for the first time, stable post-op patient with predictable outcomes, and a patient waiting for critical lab results. Which assignment is appropriate for a LPN patient? A LPN. So the newly admitted patient is going to be out of it. The patient receiving the blood for the first time is going to be out of it. So you have to choose between your stable post-op patient with predictable outcomes, or D, the patient waiting for critical lab results. So we say C, C, the patient that is having predictable outcomes, the stable post-op patient. So that is not a complex patient. So you can always give that one. Predictable outcomes, you know, the patient waiting for critical lab results, that one you want to hold on to as the nurse. LPN don't deal with anything critical. Yes, Jacinth. So D is the answer there. Remember, guys, go ahead and follow, and then you can always go ahead and subscribe to my YouTube page at Think Nursing to get the full length of the live streams. They're all posted over there for your convenience. So subscribe to the page. It's Think Nursing. It's one word. And you can also follow me on TikTok as well for the folks on YouTube at Think Nursing. Okay. Not a problem, BSN Archnell. Thank you for the follow, guys. Thank you, Natalie. I'm from Jamaica. Jamaica in the house. Wagwan. Okay. All right. What time is it? Oh, my word. I'm planning on doing a boot camp with you guys, you know. Yeah. I'm working on it. I'm working on it. Okay. RPN. Not a problem, T-Dunes. Okay, so let's go to, oh, these were the, oh, I just reached this part. Oh, no, I come from cool Manchester, Jamaica, not Kingston. Okay, so for this one, a 2-year-old with croup arrives with stridor at rest and retractions. What's the priority? A, give albuterol. B, keep the child calm and provide humidified oxygen. C, give a cough suppressant. Or D, do a throat culture. Okay, nice, Westmoreland. Okay, nice. That's from one Kingston and one. Okay, so we're neighbors. Bit of a neighbor. We're family. Family. Yeah. Oh, St. Thomas here. Welcome, welcome. My sister is in St. Thomas. Okay, so a 2-year-old with croup. What do we know about croup? What do Portland? Okay, Justin. Nice. Oh, yes, the answer. Thank you, the honest one. Lotius. Thank you for telling me. Is Lotius? No, Luke. Okay, what do we know about croup? Okay, so harsh cough. It's thank you, Natalie, for the prayers. Grenada there. Okay, Grenada. Jamaica in the club. Mansour, you're from Jamaica? New Zealand. Okay, nice. Yes. So barking cough, stridor. Yes. So with that patient, stridor at rest and retractions. What's the priority for this patient? We say, some person says B, cold is good for the lungs. Exactly. Because when I was in Maine, some of the times the patient will be coming in, and by the time they get outside and come into the hospital, it would have been reversed. So the cold air, so sometimes we usually tell the patients just open, or the parents, open the fridge door and just let the child just breathe in all of that cool air, and it usually helps. So, but B, keep the child calm and provide humidified oxygen is the priority here. Agitation worsens the obstruction. Humidified oxygen helps avoid throat exams because of the risk for spasm. Does croup use accessory muscles? So Barbara is asking, does croup use accessory muscles? Do the patient have like the retraction? Well, the answer is up there, but yeah. So the retractions, nasal flaring, do they use all of those? Yes, they do. So really surprised it's not C, it's not A, since albuterol is a bronchodilator and the patient is experiencing stridor. So for B, what is happening? So you can use, you can use the albuterol. You can use the albuterol for these patients. But with the stridor, we know that you have the, with the hoarseness and everything, as I say, it's more like, you know, I don't even know how to explain it. Bronchodilator will help, but it's not going to be, you don't want to jump onto that. There are certain things that will help with the patient. So as I say, sometimes it's just the environment that can also help, because cool here tends to help with the stridor. So I would say go ahead and put the patient on the oxygen, try to keep the child calm, and then you can always go with your medications. The least, the most invasive always. Okay, nice. So try non-meds first, then meds. Yes. Non-pharmaceutical first, and then from there. Let's just look up something here with your stridor patients. Do we have any peds nurse here? Yeah, if you can't calm them down, you can't do anything with them. Because the more they're crying, the worse it's just going to get. So you need to just get the their larynx a little bit more open up. So they will tend to have, okay, so we know that. So airway narrowing or obstruction. Yeah, so just try to make sure that you okay, so there's edema, albuterol ain't gonna fix it, so they need steroid. Who do we normally use the racemic epinephrine? They're the ones that we normally use the racemic epinephrine for. So that will help with their airway. Okay, so mild cooled mist, supportive care for moderate nebulized epinephrine, oral or IV corticosteroids such as the dexamethasone. That is what you will use to treat your croup. If it's an adult, they probably are able to calm down easier. I've never seen a croup in an adult though. Yeah, I think I've seen a few times, and you just hear you'll hear that barking cough. You'll hear that barking cough, and you'll be like, okay, then what's going on? Yeah, but the child will be like walking around, just acting normal, but they just have this cough. Isn't it just, yeah, it's a children condition, pediatric condition. So I've never seen an adult. Yeah. So SEO, so albuterol treats the lower airway. Okay. So for this one, it's more the edema, so the albuterol is not gonna help. Oh, okay. How is she doing now? How will you keep calm the child down? Give them something cool to get them a popsicle or something to suck on. I don't know. We're gonna have to just try and relax them. Try to relax them a bit. Because as I said, sometimes they have the croup and they're just acting normally. You just hear the coughing. They might be there just playing around with their tablet and they're still just acting like everything is okay. You will sing, Mrs. Rachel. Yeah, everything cool. Had to give her. Yeah, so just give them a popsicle and they'll just be there sucking on it until it does help with calming them down as well as their airway. Okay. A 4-month-old with RSV has a respiratory rate of 72 and nasal flaring. What is your first action? Mrs. Rachel, for sure. So you have a 4-month-old with RSV and a respiratory rate of 72. And nasal flaring. What is your first action? You know that this child is in respiratory distress. It's a 4-month-old, respiratory rate of 72. That's just too much. We can see the answer again. Oh my word, sorry. It's because I probably need to look on the phone. I'm trying to look over the phone to look at the projector. Okay. So what is that? Okay. So thank you for that. So the 4-month-old with RSV and the respiratory rate of 72 with nasal flaring, what action would you take first? A, suction the nares, B, give PO fluids, C, give acetaminophen, and D, give oxygen. Check the oxygen saturation. We already see the answer. So we're gonna go ahead with the A, suction the nares. Airway clearance is priority in bronchiolitis here, okay? So make sure you go ahead and do that. Give PO fluids, it's a 4-month-old, so I don't think they would be up for that right about now. Breast milk we say. Yeah man, breast milk, but then again the breast milk is going to be a little bit too thick, so that might just worsen their situation there. Give acetaminophen as indicated. Check oxygen saturation. Yes. Don't you always assess? Yes, you always assess. Why not D? Check oxygen saturation. But what is the first action? So even though assessment, airway, breathing, circulation, yes, we're still gonna assess. So suctioning, so you assess the nares, you're checking the oxygen saturation. Nasal flaring, respiratory, just think of it. You're suctioning because you assess already, right? You already assess and you realize that there is a secretion. So you go ahead and suction. I think D would be more appropriate than, but checking the oxygen saturation, is that going to help with the problem here? Would that help with fixing it? It's not going to help with fixing it because it didn't show that there's like any problem with the SAT. The respiratory rate is 72. The patient is having nasal flaring. So you assess. If there is something in the nares, you go ahead and you suction. So you're suctioning only because you know that there is a secretion. So that's how I would choose the A. But there's nothing in the question to say that the oxygen saturation is low. So you need more info, yes. So you suction to clear the airway, which is priority. So that is a priority. You're clearing the airway. The patient is having difficulty with breathing. They're having nasal flaring. So that will help with fixing the respiratory rate. Checking the oxygen saturation is not going to change anything. You'll put on the oxygen, but at the end of the day, if you have secretions there, the patient is still going to be having the nasal flaring. The patient is still going to be obstructed. The info in the question is your assessment. The clogged nares can be caused respiratory and slightly elevated. Exactly. That's why you need to assess the oxygen first. Yeah, but I'm saying, so you'll assess the oxygen. The oxygen saturation is 99. Is that going to change, is that going to change you attempting to go ahead and suction? Nasal flaring simply means work of breathing. Yes. Let's not try to dig too deep into it. Like, just think of it. If you have a patient that comes in, and you have that child that is already clogged, if that child is clogged, why are you checking the oxygen saturation? We know that probably the oxygen saturation is going to be low, but yes, it's not going to fix the problem. The first thing you want to do, so even though, yes, you're going to want to go and grab that pulse oximeter, what you need to run and get is your suction to go ahead and declog. How do we know that the nares are clogged? Well, based on the options we have here, all right, so I'm trying to find out. I'm gonna stop after probably in the next 5 minutes. I'll probably do the other one. The patient is having nasal flaring. The respiratory rate is elevated. So there is something that is causing the patient to be having that distress. So yes, you use the airway, breathing, circulation. Checking your oxygen saturation is not going to address or help with fixing the problem. Because even if you check the oxygen saturation and you go about with putting on some oxygen because it's low, the patient is still clogged. So you need to go ahead and, hold on there. Nasopharynx does not necessarily indicate clog. Yes, it doesn't necessarily indicate, but the first thing I would do is check the oxygen and then the veneers. Okay. The nasopharynx respiratory means oxygenation is off, so that's why D, right? So, okay, so you check the SAT. All right, let's say you check the SAT. You check the SAT and you get a SAT of what? 85. You get a SAT of 85. You're gonna put on the oxygen on the patient. It says suction the nose. I just checked Google. Yeah, that's the answer. You don't like the question? It says first action. What is the first action? So even though we know that oxygen, you want to check the oxygen saturation. It doesn't have to be that is the first thing you're going to be doing. We're going to do it, but it's not normal for the child to be breathing like that. It is not normal for them to be having the nasal flaring. But I'm just saying, if you check the oxygen saturation, you put on the oxygen, the patient is still going to be having the nasal flaring, the respiratory rate. There might be, it's RSV. We know that with RSV, what is going on? You have a lot of secretion. So try and understand the pathophysiology behind RSV. And then from there, what is it that you need to get done? What you need to get done in order to clear up and help with that patient's respiratory rate and the nasal flaring. You need to get rid of the secretion. So you have to suction the patient. So that is the first thing you're going to do. This is more emergent. With respiratory being 72, suction first. Oxygen saturation is not going to change outcome. Exactly. Secretions are the symptoms that is concerning. The suction will alleviate the 4-month breathing immediately. The answer is A. Priority means all of them, right? Intervene. So we'd assume yes. So just don't think too hard into the question. All right. Hope that helps with explaining. Don't overthink the question too much. All right. Just look at the condition. What's the pathophysiology behind it? And whatever it is that needs to be fixed, you go ahead and fix that problem. All right. This is a lot. All right. Let's move on to a different one. Okay. So this is the last question. Yes, it can help as well. It can help as well. Ask yourself, if I could only do one thing, would I suction or would I check the oxygen sat? Okay, Breedy on mask. Thank you for that. So, respiratory distress. Ijang, thank you for that. Yeah, just don't read into the question. Don't add anything to the question. Don't take anything away from the question. A newborn has a heart rate of 90, weak cry, bluish extremities. What's the priority for this patient? So a newborn has a heart rate of 90, weak cry, bluish extremities. Priority, what's that for the patient? A, suction the mouth, then the nose. B, start chest compression. C, warm the infant. Or D, provide PPV. So a newborn has a heart rate of 90, weak cry, bluish extremities. What's your priority? Let's see. Tariq, welcome, welcome. Always airway breathing circulation. Okay. So what's your priority? So I see A, Brian says D. Okay, nice. So let's look at it. So you have this newborn. What's the expected heart rate for your child, your newborn? What's the expected heart rate? What's the expected heart rate for your patients? A newborn. 80 to 100. The heart rate is low. So 120, 160, 140, 160. Okay, so it should be anywhere between like 140 to 160. You know what? Let me look up pediatric. Hold on. Let's look up the heart rate. But this heart rate is low. It should be in like the 160. So, newborn heart rate. So newborn heart rate should be anywhere. Okay, so at birth, it's going to be 120, 160. When they're sleeping, 120, 100 to 120. Crying, 160 to 180. Okay, so 120 to 160 immediately after birth. If they're crying, then it's going to be a little bit high. So the heart rate is 90, which is very, very low. The patient is having weak cry, bluish extremities. I know some persons were saying cyanosis with the bluish extremities, which would have been normal, but this child is having a weak cry and the heart rate. So suction in the mouth, then the nose. Yes, these are things that we're going to be doing. But what is priority for this patient? Are you going to start chest compression? Are you going to warm the feet? Are you going to provide positive pressure ventilation to help with this child? So, although suctioning may help, it's not what you would do first. Exactly. So, even though you might have your airway breathing circulation, what needs to be done for this patient is, I see person saying D, bagging won't do any good if the airway isn't clear. First things first, get to your bagger. So, your PPV, okay, you want to go ahead and start your PPV. So you're going to bag that patient, start positive pressure ventilation. That is what you're going to need for this child. So warming the feet not going to help because this heart rate is very low. You need to get this patient up to the 120s. Starting chest compression, you're close to there, but bagging the patient, start ventilating this patient. It's a newborn. Try to ventilate this patient and see if that will help. Suction mouth, then nose. Yeah, we'll do that. C makes no sense. Exactly. That's when you're trying to get the little blood from the heel. When they're in. ICU nurse for 15, always get your bagger. Yes. Thank God I didn't change my answer. So you bag when you eventually suction. Yeah, you will suction, but the priority for this patient is gonna be the to go ahead with getting your bag mask ventilation going. All right, so even though we say that you have airway breathing circulation, just think about what is gonna kill the patient. You need to address that problem. So even though suctioning is gonna help with the airway, you know, getting rid of that secretion, you need to start your bag mask ventilation because this child has the bluish extremity, the weak cry, and the mere fact that the child is having a weak cry, it's not so bad in terms of the suctioning. All right, so go ahead and get your bag mask ventilation started, and then from there you go ahead and get the heart rate up. So you do your PPV, your bag mask ventilation, suction in the mouth and the nose, and then from there, I understand D, and that's why I put it. But if I get oxygen in due to secretions, go check the NRP. Okay, no problem. Bite size, I see normal range 100 to 160. Would you do that at the same time? Yeah, you're gonna do it. Everything is just gonna be happening at the same time. But just think about what is the safest thing to do for this patient to get the heart rate up, to help with that cry, that weak cry, to help with the bluest extremities. The patient needs oxygen. All right, so you need to go ahead and do that. But if there's secretion, would bagging help? It's not gonna be that. Bagging is gonna help. It's gonna help. You'll suction in the meantime. So it's asking for priority, not first action. Exactly. Thank you for that, Tiff. Thank you for that. So remember, so I want you guys to look up like first action, priority, initial. What else? They have some words that they normally use. So look up those so you can have a better understanding of what the words mean. So the priority for this patient would be to get the oxygen going, the bag mask ventilation going. But the first action, if you were supposed to do the first action, you want to go ahead and suction the mouth and the nose. All right. But the priority for this patient is to get oxygen going for this patient because the heart rate is too low. Okay. Question. Let me just go through this one here, seeing that answer already. A child with epiglottitis arrives drooling, anxious, leaning forward. What's the priority? priority. A, inspect the throat and with a tongue blade for intubation. C, give oral antibiotics. D, give cough syrup, and it's going to be prepare for intubation. The mere fact that this child, this person is drooling, the person is drooling, anxious, leaning forward. The child has epiglottitis, it's an emergency. The drooling, no fluid is going down. So you would want to go ahead and prepare this patient for intubation because it's obstructed. Their airway is obstructed. So it's in a tripod position, airway obstruction, nice. I've seen this question on a practice question on UWorld. Okay. So never place anything in the mouth, good. So prepare the patient for intubation, give oral antibiotics. The patient can't keep anything down, so giving oral antibiotics is gonna just drool back out or put the patient at risk for choking. And it's the same thing, cough syrup is the same oral. Never put anything in the mouth, yes. I yield NCLEX. All right, so that is it for tonight with these questions. Let me just mark here. I think we did that one. Let me just put a mark beside this one. Yeah, so well, let me turn this thing here because I'll go on. How you guys doing? You're welcome to do forgot trail that up and read on them. So tomorrow night, we're coming back tomorrow night. I'm not working tomorrow night, so tomorrow night probably end up doing probably a few hours just the same. Usually Thursday night would be this time. The length for the live tonight would have been on Thursday night. I wasn't doing anything much, so tomorrow we'll do priority or what. Yeah, I was gonna do some more priority question. I think I have some more pediatrics here. So it's gonna be 7 p.m. Central Standard Time tomorrow. No problem, Justin. And then we will also go through, we did the delegation. Let me see what I had here. A little bit of a pathophysiology was added to it as well. So yeah, I had some pathophysiology. Try to mix it up so we don't get bored. Can we do mental health sometimes? I'll add some mental health to it as well. And then from there, not a problem, Jacinth. Yeah, so yes, most of my family is in Jamaica. They're doing okay though. Yeah, they're doing okay. Thank you for asking. So it's gonna be 7 p.m. Central Standard Time. So my time now is 11 o'clock. Wow. My time now is 11 o'clock. So I don't know. So I'll start at 7 o'clock tomorrow in the night, and then from there. So Saturday. Who asked about Saturday? You know, so Saturday I'm an off day. Saturday a church day. Time for relax and lie down in a bed. Huh? I was thinking about doing a boot camp with you guys on I was gonna ask you guys if probably Sunday, but then again Sunday I'm an off day as well. So I'm thinking about a day. I'll work on it, and then we can do a boot camp where we go for a few hours. At least once a week. So that way I'm gonna cut out all of these long hours. Monday? No, Barbara. No, Monday is it's a Saturday and Monday. Monday is the week, it is the start of the week. Monday is not a good day to start. Everybody's gonna feel bored on Monday. Yeah. Yes, I am. If 2 GB. Yes, I am a 7-day Adventist. 12 o'clock in New Jersey. Okay, so you're 1 hour ahead. Yeah, I was thinking about doing that, and then from there, okay, nice. And then from there, we can cover, a few questions. We want to pass NCLEX, so we will make time. Okay, I know you guys will. So I'm gonna try to get the UWorld. So Tuesday or Wednesday. So probably it will be a Wednesday because I don't work on Thursday and Friday for now. So we'll see. We'll see how that goes. So, but I'm gonna do one, and we'll try to see if I can do probably 2 hours, 2 hours, and then from there. Oh, your AC exam is Monday. Okay, nice. You're gonna do well a little bit. So UWorld, I know a lot of persons says that they've been using UWorld. The questions seem to be okay. I haven't subscribed or purchased it as yet. I haven't purchased it as yet, but I know a lot of persons talk about it. So the questions I'm using are questions that I created, got them from the internet, put them together, asked a lot of questions, in the meantime, just to cover a lot of content for each. Yes, so a lot of persons say UWorld is good. Yeah, but I didn't want to get UWorld until I have a certain amount of persons on the, studying here. So it makes sense because it's very costly. So we have to figure it out. But I'm going to do some boot camp. It's going to be similar to these. It's going to be pretty reasonable. All right. It's going to be pretty reasonable. So we can do smaller group study. It doesn't matter the question bank, you have to know your content. Exactly. And that's what I keep on telling persons. Bootcamp questions too easy. Oh, man, I really know much about the bootcamp, Dr. Clem. I just know that I was going to use the same technique here, the same thing I'm doing. I'm putting some time and have you guys come over that side. So for the bootcamp. So I know everybody is doing the NCLEX a little bit different. Everybody's doing everything a little bit different, but mine, I want it to be more a comprehensive study. Archer is okay. I hear about Archer as well. Not easy, but vague like NCLEX. Okay. Bootcamp is good for case studies. Archer as a 3-day live class. I think 8 hours each. Okay. Archer is expensive. Yeah, I was looking on the prices. They're expensive. They're expensive. But you have to know your content though. I always tell people you have to study. Find the time to study and know the conditions, because if you don't understand it, it's going to be difficult for you. Because when it comes down to prioritization, delegation, it's going to be based off the fact that you understand the pathophysiology. So you can say, oh, that this patient is going to decompensate, or the prognosis look really bad on this patient. I'm going to keep this patient and, delegate to somebody else. So you have to understand what is going on with the pathophysiology, and then from there you will be able to delegate and prioritize care. It's so much to know. I sat myself out real bad. Remember, NCLEX is trying to find out or trying to test you on safety. So it's all about the safety of the patient yourself. So in as much as, yes, you have to understand the condition itself, don't think too hard about the question. Don't think too hard about the question. Just, as I say, use the different things, the techniques that they talk about, your airway, breathing, circulation. And if it is something that is common to the condition, don't dwell on it too much. If it is something that is common to the condition, don't find yourself going over there and trying to, address that situation while you have a patient that has something else going on that is going to die on you. So it's so much. Don't subscribe to too many question banks, because you will. Exactly. And that's the other thing. Do not try to, be using too many things to study, because eventually it will confuse you. What's the REX-PN and the LPN exam? No, not right now, Barbara. I haven't looked on that too much as yet. Let me write it down. Where is my book? Only use Archer Pass on 80. NCLEX is heavy on case study. Okay. Exam for RN in Canada. Okay, so I guess Manny is asking the one below on my CPR. Yeah, I don't know much about that exam. Yeah, so let me just add it to this thing here. So psychosocial. Tell me LP and USP. Oh, Dan, welcome. I don't understand. Can you tell me LP and USPs? What's that? Ari Kai, welcome. How are you? Oh, the test? If that's what we're studying for? I'm doing fine, thanks. Oh, okay. I can help you as much as I can. I can help you as much as I can in terms of with just studying, but I don't know much about the LPN exam. So what textbook you guys use? I have this book here. I have this book. I think it's for the. Is it CNA book? I don't even know how I ended up with it. I think it's like a CNA textbook I have. I don't even know where it's at. Let us say I could actually prepare some questions later on, but I'm still trying to get something sorted out. And then from there, so I think this is a CNA. I think it's a CNA book. I don't know. I think it's CNA. Can't hold it up too long because then TT will get upset at me and tell me not to show up anything on their platform. But the content I cover is, is gonna help you with your LPN. You just have to know the different roles and responsibilities. So that's the only thing I think is gonna be different. Your roles and and responsibility. But in terms of content for pathophysiology and all, yes, Saunders is good for LPN. LPN study the same stuff. Okay. The stress is terrible. Different scope of practice. Yeah, so that is what I'm thinking. But in terms of the condition, it will still help you here. Questions are the same for LPN and RN, basically, except the scope of practice. Okay. Yeah, so I will see you guys tomorrow. I will definitely see you guys tomorrow. And as I say, just in case you come onto the live late, you can always check out my YouTube page. I think Nursing. I do post the contents over there, or it's live stream over that side. One resource is good. Saunders. So you can always check out the page, subscribe to the page, and watch the video at your own convenience. And then from there. Thank you, Miss Little Bit. Little Bit, where you come from? Know your scope of practice and fundamentals. Definitely needed as a practical nurse. Okay, Jerry, nice. You're welcome, Barbara. You're welcome. Who is over by YouTube here? Who is over by YouTube? You want to just type something, say hello. Oh, you're living in Florida? Okay, nice. Thank you for the follow. I was in Florida the other day. It was good, except that rain. Yeah, I can't deal with the rain of Florida. Every day it rain. Every day. But it was good. I did enjoy myself. I did a road trip to Florida. It was what? 16 hours worth of driving? It was good. Did enjoy it. I wish I had a drone at the time. You're in Massachusetts? Oh, you're from Grenada? Okay. I met a few persons from Grenada the other day. Yeah, hopefully one day I'll be able to go to Grenada. Not so sure. Yeah. How is your family though, a little bit in Jamaica? And I know someone had said they're from Westmoreland. I don't know if that person is still on the live. I think I was asking about their relative in Westmoreland. I have some, my husband's family they do have relatives in Westmoreland. I think they lost everything. Oh, them okay. Oh, Mandeville. Well, I don't really come from the heart of Mandeville, but I come from South Manchester. From, I don't know if you know North Patrick side, Asia. That's the side I'm from. Yeah. That's home for me. So we never get washed away, thankfully, which is nice. But I want to go down to help out with some volunteer service. Still waiting for Mr. Christopher Tufton, assistant to get back at me. But the only thing the gentleman said, or I don't know if it's a gentleman or a lady, the only thing they said was send contact details. I say I was so upset when I saw the message. After my family made me nice little message and texted to them, that was the only thing I got. I'm like, okay then, this not even make no sense. But yeah, I really want to go down and do some volunteer service. If not this year, it's gonna be next year. Because if I go down on my personal time, I just feel as though I'm not gonna be that productive, because I'm not gonna be able to get to the sites that I really want to. Jerry is saying, see you on Saturday. Jerry, who tell you that I'm coming back on Saturday? I'm not coming on Saturday. I'm coming tomorrow. I'm going to be on the live tomorrow. So, Saturday. No, I have things I'm going to do Saturday. Yes, I'll probably pop on the live for Saturday. But Saturday lives are usually for, just chit-chat. Just come and just say hello. But it's not for any question. All right, then no problem. All right then, guys. Well, enjoy your night. Enjoy your night. Miss Grenada, enjoy your night. Hope you will have a wonderful night. Miss Lickabit, we will chat. Remember to go ahead and follow me. All right, I will follow you guys. Sometimes TikTok don't allow you to follow, and then sometimes I tend to forget. But go ahead and follow the page so you can always see whenever I go live to get your questions done. All right. Until then, I will see you in the next video. I'll see you on another day. All right, bye. All right, enjoy your night now. Bye, everyone on the live. Oh, remember to claim your daily heart meals. So the heart up here, you need to claim it. That would be nice. Westmoreland really, yeah. I hear about it. I am like devastated about the whole thing. My in-laws sister is a nurse in Spanish Town, and they went to St. Elizabeth. They went to Black River, and they said that, yeah, it's awful. It's really bad. It's really bad. So there's a fire at cave. Which cave? I don't know much about Westmoreland. I've passed through Westmoreland a few times, but it was like in my younger years going on church trips. Say a long time. I never have no reason to go Westmoreland side. Yeah, so. But I hope everybody is doing okay, though. I hope everybody is doing okay. As much as, okay is. You're welcome, Jay Arif. You're welcome. All right, then. Let me go. It's after 11. All right, that's after 11. Let me go and get a nap. And then from there, enjoy your night now, guys. And thank you. Before you reach Bluefield. Okay. Me know Bluefield. We used to go there a lot for church trip. Bluefields Beach. Yeah, okay. But it has been a while, though. It has been a while. But I hope everybody is okay. Gonna take some time to rebuild, but at least we have life. Just hope that we come together and do the thing right. Yeah, that's just it. All right, but thank you so much for tuning in. I will see you guys in the next live. Just get some rest. All right, bye. Oh my word.